insight, and clinical excellence. Our theme this year, the science behind the symptoms, decoding disease from bench to bedside, invites us to go beyond surface level presentations and explore the deeper mechanisms that drive disease and guide recovery. We are truly privileged to have among us a galaxy of eminent doctors, renowned academicians, and respected clinicians, each a torchbearer in their field, who have graciously joined us to share their wisdom and experience. This platform opens the door to knowledge and encourages us to walk together on a path that bridges the science of the bench with the art of healing at the bedside. We also extend a warm welcome to all the delegates, postgraduates, interns, and students who have joined us. We hope this day will be filled with learning, discussions, and fresh ideas that help us grow as better clinicians. Once again, welcome to ADAMCOM 3. Let us make this a meaningful and memorable experience for everyone.
Let us begin our first scientific session of the day. Infarct pattern recognition in ischemic stroke. Ischemic stroke, a major contributor to morbidity and mortality in today's world, often presents as a clinical puzzle. Recognizing specific infarct patterns on imaging is not just a radiological exercise. It is a vital step in uncovering the underlying vascular pathology and tailoring appropriate management. Timely identification of infarct patterns helps tailor treatment and improve outcomes. To chair this session, we have Dr. Ajay Kumar Ayyappan Unnithan Sir, Consultant Neurosurgeon, AZEEZIA Medical College, and Dr. Amod Sir, Consultant Neurologist, AZEEZIA Medical College. I now invite our speaker for this session, Dr. Sesh Shivadasan Sir, Consultant Neurologist, Holy Cross Hospital, a keen academic eye with a vast clinical experience in the field of stroke medicine.
Hello. Okay. First of all, respected chairpersons and respected faculty members, I thank everyone for inviting me to deliver this presentation. And I also thank Rajasekhran sir, meeting him after almost 10 years actually, and for inviting me to deliver this talk. And thank you each one of the coordinators in ADAMCOM for inviting me to deliver this lecture. So I will, it is a bit lengthy session, but I'll try to make it very brief. Okay. So we have two imaging modalities we have available in stroke, basically CT or MRI. So CT we can take either plain CT, angio and perfusion. MRI we can take either plain MR angiogram, diffusion and perfusion. So these are the basic imaging modalities that everyone should know of. So there are four things that you have to mainly concentrate when looking at the imaging in an acute stroke. These are the four P's actually. So one is parenchyma, that look for the early ischemic changes, and the pipes, basically the vessels or the blood vessels which supply the infarcted area. Then the perfusion. Perfusion is actually the amount of blood flow that is arriving at different areas, and then the penumbra, that is the what we are targeting is the penumbra. So that is the area at risk of ischemia or infarction if not intervened. That is the penumbra. So what will you do? First, imaging, CT or MRI, which is better? So of course CT has different drawbacks. Usually very small infarcts are usually missed. And of course everyone knows posterior circulation strokes, very difficult to get with the CT. And pattern recognition is very difficult. What is pattern recognition? I will come to you in a short while. And stroke mimics can be missed. That is very dangerous. Sometimes postictal weakness we will thrombolize, and sometimes a small tumor or a vascular malformation can mimic a stroke. If you take a CT only, then you will thrombolize and you will land up in trouble. So CTs, the stroke mimics can be missed. So this can be very disastrous. And if at all the patient presents with a dense weakness, with a large NIHSS, poor GCS, obviously there will be a large bleed or a large infarct, so or a large vessel occlusion. Then CT with the CT angiogram is preferred, so that we will pick up all the findings. But if it is in a small or moderate size infarct, you are doubtful whether it is a stroke or there is stroke mimic. If it is a posterior circulation stroke, definitely MRI is preferred. Only point is that MRI takes at least 15 to 20 minutes to complete 3 sequences. So posterior circulation strokes, small infarcts, for pattern recognition, etc., it is definitely MRI is better. So why do you want to recognize a pattern in infarct? So from a physician's point of view, the infarct is there, you treat with aspirin or secondary prophylactic medications, look for any causes. Why do you want to recognize a pattern? So pattern, first you have to notice what is the vascular territory that is involved. That everyone will look into, whether it is ACA, MCA, PCL and all. Then from the patterns you get hints to the stroke etiology, why that stroke is occurring. So stroke is not just merely a disease, it is actually a syndrome where multiple causes are there. There can be innumerable causes which cause the stroke. So this pattern can shed light into the cause of the stroke. And evaluation of recurrent stroke, of course, you definitely need the pattern recognition. And for that, diffusion weighted MRI images. So now MRI reading is actually very simple. Don't think that it is very complicated and all. Everyone, even simple physicians and postgraduates can read an MRI. So diffusion weighted images is very simple. And but the problem is that even if you recognize the pattern, it need not necessarily point at the correct etiology. So because the patterns can mimic in various etiologies. Now the stroke classification, that before going into the pattern, the stroke classification is very important, the stroke etiology type classification. So you use the TOS classification. This in Harrison and all, it is not actually mentioned. I don't know, the newer editions are mentioning TOS classification, but it is very, very useful, and it is being used in almost all the studies that come in stroke. So that is the etiology based classification of ischemic stroke. So there is, first is large artery atherosclerosis. So it can be an extracranial carotid stenosis or intracranial stenosis, and it can produce an embolus. So, or there is an artery to artery embolism or thrombosis. Second is cardioembolism, everybody knows. Third is a small vessel disease, the lacunar stroke. And fourth is strokes of other determined etiology like polycythemia, vasculitis, etc. And fifth is stroke of undetermined, approximately 20% of the cases, the strokes are of undetermined etiology. Now this is the diffusion weighted MRI. So here you can see the see, this is a diffusion weighted image. As you can see the diffusion hyperintensity, which is seen as a white, and the corresponding ADC maps, it is seen as black. So this is the basic diffusion weighted imaging. This everybody should be aware of. Even the graduate level and postgraduate level, everyone should be aware of this basic diffusion weighted imaging. So it's very simple. Time taken is less than 3 minutes. And if you add an MR angiogram, it is diagnostic accuracy increases. Now, the different patterns, what are the different patterns infarcts occur. So these are the major points that I have taken from an article by James Joser, who is a professor at Calicut Medical College. So he has written a review in IAN. So the major, in fact, patterns I have taken from his article. Now, these are the common patterns actually. So these are the cortical infarcts, lacunar infarcts. I will go through this individually and briefly. Now, these are the, as everyone knows, these are the cortical territorial infarcts. That's the infarct, that's the diffusion is seen restricting in the particular arterial territory. This territory, everyone knows it is the ACA territory, this is the MCA territory, this is the PCA territory. So this is the cortical territorial infarct, this everybody knows. Now this figure is a CT. Here you can see the both the ACA as well as the MCA is involved. So the ACA as well as part of the MCA is involved. Both arterial territories are involved. And if you here look at this picture, they see this whole hemisphere is involved except the right ACA territory. So the right ACA and right PCA is involved. So PCA is from the posterior circulation. So how come it is involving in the MCA? It means that the PCA is arising from the anterior circulation through the fetal PCA. So that's why it is producing a fetal PCA and producing an infarct, which looks like a hemispheric infarct. This can also occur if there is a large MCA infarct, the edema can compress the PCA and also produce an infarct. Now this is another large MCA infarct with a subcortical as well as cortical infarct, and you can see the right ICA is completely missing. So this is an ICA disease, but the thing you can notice is that the cortex is anterior cortex is relatively spared. Even if there is no vessels in the right hemisphere, the cortex is relatively spared, and that means that there is good collaterals in this area, and there is collateral perfusion coming from the opposite side. So and it is a slow thrombus. If it is an acute thrombus completely occluding the ICA, the whole of this hemisphere will be infarcted. So if this picture is there, it means that the patient has a good collaterals and a patient is likely to survive more. Now the next pattern is this cortical infarct can be fragmented. So this is an MCA territory, but you can see the infarcts are fragmented. Some are here, some are subcortical in the caudate and lendiform, some are in the M2 region and all. So these are fragmented MCA infarcts. Okay. Now the next pattern is the deep territorial infarcts. Deep territorial infarcts means it is in the territory of an arterial major artery, but it is very deeply located in the basal ganglia. Well, if you look carefully, it looks like a coma-shaped infarct. It's like a very looks like a coma, or turned to the other side, and it is usually due to the occlusion of more than one adjacent lendifostriate arteries that I will come to you in a short while. These are the lendiculostriate arteries. So you can see the ICA coming, bifurcating as AC and MCA. The MCA goes through the sylvian fissure and it gives off the lendiculostriate arteries. So these lendiculostriate arteries, if there is a thrombus that is coming here, it will occlude 2 or 3 lendiculostriate arteries together. So it produces an infarct, especially involving the caudate and the anterior limb of the internal capsule. So that is the pattern. That is, if you look at that, the caudate and the anterior limb of the internal capsule and lendiform is involved. So that is the pattern that occur in a striatocapsular infarcts. That is called the lendiculostriate infarcts. So why, if there is a thrombus here and the distal part is spared, means that either it will be a partial thrombus or the collateral flow is so much that the cortex is spared. So that's why the cortex is spared. The thrombus is only a partial thrombus, or it could be a main thrombus that is recanalized and it is occluding the perforators from here. So that is what protrudes in the picture. So this is the striatocapsular infarct. It is a coma-shaped infarct. So it is 3 to 4.5 centimeters. And what are the areas that are spared is the globus pallidus, posterior limb of the internal capsule, and overlying cortex is spared. So that is the striatocapsular infarct. Now other pattern is the superficial perforator infarct. If you look at the vessel here is the main ICA that is coming, and it goes to the limb fissure as the MCA, you can see the basal ganglia perforating arteries. And if you go to the surface, it divides at the M2 branches and it forms a pial plexus over the cortex. And from the pial plexus, the superficial perforating arterioles come and supply the white matter above the lateral ventricle. So this white matter above the lateral ventricle is called a centrum semioval. Some of the reports you will see centrum semioval area, which is supplied by the superficial perforating arterioles. Now, see the infarcts are confined to this area. Now the pial branches, these are 2 to 5 centimeter long end arteries. So the white matter of the centrum semioval is involved. So these are the small punctate, these are the images which shows the small superficial punctate infarcts over the centrum semioval region. Superficially located spotty lesions, and the innermost lining is taken as the, so many guidelines are there why to call it as so that we can skip all those things. These are the scattered superficially located subcortical infarcts. Then the most important one of this is watershed infarct. This you should identify very correctly. There are two types of watershed infarct, the cortical watershed and the deep watershed. So I will show you. So again the same picture. So this is the deep perforators, the basal ganglia perforators, and these are the superficial arteries with perforators. And this area is actually a watershed area. If there is a proximal thrombus here, there is hypoperfusion, and there is high likely that these watershed areas getting infarcted. So these are the areas between deep and superficial perforating arteries. Anatomically lies in the white matter slightly above the lateral ventricles. So these are hypoperfusion infarcts. Okay, so I will show the images. So this is the area which produces the hypoperfusion watershed infarcts. So you can see the diffusion weighted images. See, these are the watershed internal. There are two types of watershed infarcts: the internal watershed infarcts and the cortical watershed. These are the cortical internal watershed infarcts, where there is the watershed areas between the deep perforators and the superficial perforators. So you can see the chain like sausage like small lesions. Whenever you see this, you conclude that there is a proximal thrombus either in the intracranial ICA or in the carotid system. So you can see there is it can be either patchy or confluent. So the confluent infarcts are larger and cigar shaped, and the partial infarcts are chain-like, bead-like, like a string of pearls. So there is very classical of a hypoperfusion infarcts along the side of the lateral ventricle and the centrum semioval. This is the centrum semioval. Centrum semioval is basically the white matter above the lateral ventricle. So this again, you can see the multiple chain-like infarcts along the internal watershed region. So you can see here the right cavernous IC is normal, the left cavernous IC there is a signal drop suggestive of a thrombus here, and whenever the BP is lowered you get the hypoperfusion infarct. That's why you should say in acute infarct never lower the blood pressure unless it is highly indicated. Now you can see there is a internal watershed infarct here, like a chain of beads. You can see the thrombus with an ulcerated plaque in the left cavernous ICA. Left internal ICA at the ICA origin at the neck. So internal watershed infarcts, usually large artery atherosclerosis or ICAD is basically intracranial atherosclerosis disease. So there is microembolism from the site or hemodynamic failure or the hypoperfusion infarcts. Okay. Now the second most important watershed area is the cortical watershed area. See, you can see this is the ACA territory and this is the MCA territory. So from both these areas there is a narrow area which is not covered by either of these territories, either of these arterial arteries. So there is the anterior watershed or the ACA MCA watershed region, or you can see the MCA PCA watershed region. So that is located posteriorly. So these type of infarcts you can mainly see in cardioembolic sources of stroke. See, these are the anterior cortical watershed region and the other is the posterior cortical watershed region. So I will show you more. See, this is the anterior, this is the ACA, this is the ACA territory, this is the MCA territory. So there is an infarct in the MCA ACA watershed region. This is the MCA PCA watershed infarct. is a wedge-shaped infarct. Usually these kind of infarcts are produced by cardioembolism, but large artery atherosclerosis can also produce. Now the third type of infarct everyone knows is the lacunar infarct. The lacunar infarct usually overdiagnosed or misdiagnosed in many cases. You can see radiology reports, they report a small lacunar infarct in the cortex. So usually that is not the case. So lacunar infarcts are very small infarcts. The common locations are basal ganglia, thalamus, brainstem, especially the pons, and internal capsule and deep white matter. So we have to classically, the most important thing is single perforating artery is involved. That is the catch in this, single perf. So you can see the small infarct, usually 1 or 2 sections it will be seen. This everybody knows this lacunar infarct. Usually a small hyperintensive, less than 15 millimeter, a single perforating artery is involved. And the pathology is different, not arteriosclerosis, it is lipohyalinosis. So lacunar stroke and lacunar syndrome is different. Lacunar syndrome is actually the clinical presentation. Lacunar stroke, the pathology, it signifies the pathology, the lipohyalinosis. Now you can see the thalamic infarct and you can see the vessels are completely normal. So in these cases the pathology is not arteriosclerosis, it is lipohyalinosis, just chronic hypertension and microangiopathy. So these are the again the infarcts in the single perforated artery, lipohyalinosis. So these are the lacunar syndromes that commonly asked in exam. You can have the pure motor stroke, pure ataxic hemiparesis, ataxia, clumsy hand syndrome. These are the lacunar syndromes. Now, one of the most underrated causes is the bad atheromatous disease. So this is a type of a new finding that is described in the last 10-15 years. So here you can have a plaque which is a plaque which is obliterating the the origin of the penetrating artery. Here you can see a plaque which is partially obliterating the penetrating artery and it is going into the lumen, and there is another plaque you can see here in the image C which is completely occluding the lumen. So these are the branch atheromatous disease. Now it looks like a lacunar infarct. It looks exactly like a lacunar. So the problem is it occurs in multiple sections. It is bigger than a lacunar infarct. It is extending up to the down section. See, up to the multiple, more than 5 millimeter cuts you can see the diffusion. And it is associated with atherosclerotic disease or MCA or the basilar artery. See, I will take a few. See, this is a infarct in the right lendiform, posterior lendiform and corona radiata. If you see the vessel wall, it is MR angiogram is entirely normal. And if you see the cut section in a high resolution vessel wall imaging, it is also completely normal. Here, it is completely normal. So this is lacunar stroke. And if you see this slide, this is again looking like a lacunar. But if you look at the cross section, the TOF will also, the TOF angiogram will also look normal. Either the C3 angiogram will also look normal. But if you do the vessel wall imaging, you can see the plaque which is obliterating the perforating artery. So this is called a branch atheromatous disease, exactly mimics a lacunar stroke. So this is first one is a lacunar, second one is a branch atheromatous disease. So this is the things that I have already told. Now BAD, bad disease, located proximally along the perforators. These have larger infarcts and poorer prognosis, and duration of hospital stay is high, and worsening more than 24 to 48 hours is well known. 5 more minutes can I take? The long insular artery, I will skip all this insular artery. Then I will show the infarct pattern versus stroke etiology. Now the stroke etiology first is large artery atherosclerosis. The classical definition is more than 50% stenosis of intracranial or extracranial arteries. And you can see here there is an infarct in the left MCA territory, and you can see the angiogram that is showing the tight stenosis in the left MCA M1 segment. And you can see the another image showing the carotid stenosis Carotid stenosis. So this is a large artery atherosclerosis. And in this image, you can see the a multiple infarct. Here the internal watershed and cortical infarct. And you can see the 3D reconstruction of the vessel wall imaging showing the atheromatous plaque, you can see. And the coronal reconstruction also seems the same. Now cardioembolism, everybody knows. At least you have to demonstrate a cardiac source of embolus, either by atrial fibrillation, flutter, Sixth syndrome, or thrombus in the echo. And usual features are multiple vascular territories. You can see the left MCA is involved, the right multiple small infarcts here and here. Or if a pattern looks like this, most likely it will be cardioembolism. So multiple arterial territories, bihemispheric infarcts, both anterior and posterior circulation infarcts, early hemorrhagic transformation. These patients, cardioembolic stroke, if you thrombolize, very high risk of hemorrhagic transformation. Then cortical infarcts. Then most important is the SC territory and the insular infarcts also confirm. So this is like a shower of emboli. These things you have seen in your ICU patient, like a septic emboli, like a shower of emboli. So this is a posterior circulation, few words. Posterior circulation, you look at the ponds, three major etiologies. One is the large artery atherosclerosis. You can see the basilar artery is tightly stenosed here. And look at the pattern of infarct. See, there is a large infarct, paramedian pontine infarct, extending from the surface up to almost the dorsal surface of the pons. And you can see the branched atheromatous disease. Again, it look like exactly the same, but the branch atheroma is obliterating the penetrating vessels. And here, in the last image, the top is completely normal, but you can see a tiny infarct in the paramedian. This usually presents like this 1.5 syndrome. So you will see the MRI coronal images will show a small infarct. Now cerebellar infarct, this is the SCA territory. SCA territory, if there is an infarct, you always look for a cardioembolism. This is the ICA infarct, this is the PICA infarct. Now you can see, is there any correlation between the infarct and the etiology? So this is a study from Korea. Actually they have looked at patients. This is an interesting slide actually. You can see the MCA, ACA infarcts and all. And what are the etiologies based on the TOS classification? If you look at the MCA, one second. See, if you look at the ACA, MCA, ICA, vertebral artery, PICA, ICA, all those things, the highest contribution is by the large artery atherosclerosis. And if you look at the basilar arteries, if you look at the pontine infarct, mostly it is small vessel disease. There is a lacunar infarct. And if you look at this superior cerebral artery, the 60% of the cases, it is cardioembolism. So these are the hinters towards the etiology of the stroke. So large artery atherosclerosis is the most common etiology. Among the common etiology in ACA, MCA, vertebral artery, ICA and PICA stroke. Superior cerebral artery territory, cardioembolism is very common. Small vessel stroke, the most common etiology in the basilar artery and PCA stroke. And multiple vascular territories in the anterior circulation is cardioembolism. But if you look at the posterior circulation, multiple vascular territories in the posterior circulation is usually large artery atherosclerosis, so the vertebral or basilar stenosis. Okay, thank you.
Thank you for the wonderful and illustrated talk, Dr. Shesh. I have one question. Whether there is any relation between internal watershed infarct and leukoariosis?
Leukoariosis. Most of the, when you get the MR reporting, you will see leukoaerotic changes. The leukoaerotic changes is basically the small vessel disease. Small vessel disease, I will show the slide. I wanted to show a slide, I didn't take actually. Leukoaerosis. Leukoaerosis is different from internal watershed infarcts. Internal watershed infarct is due to hypoperfusion, and leukoaerosis is due to the small vessel lipohyalinosis that is producing the leukoaerotic type of picture. The white matter disease, it's called Binswanger's in the olden days. White matter disease producing small vessel disease. It is different from hypoperfusion infarcts. Hypoperfusion infarcts, the major vessel is supplying the area is stenosed, which is producing the hemodynamic hypoperfusion, and it produces a string-like occlusion. But if the infarct is, the imaging is taken 1 month later, both will look like the same. It cannot be differentiate between the leukoaerosis changes or the hypoperfusion infarct. If it is in an acute setting, the diffusion can show certain differences, but the leukocytic changes the white matter disease. That in chronic hypertension, it is the pathology is different in from hyperperfusion.
Thank you, sir, for the wonderful talk. Can any questions from the audience?
So, Dr. Shesh, that's an excellent presentation.
Thank you,
I think I'm meeting you after 10 years.
10 years, sir.
10 years. So, we as we physicians are the products of 84 PG batch, in which CT had barely come inside. Okay. So, at this stage, what would you suggest? You depend on CT or MRI?
I would suggest better depend on MRI because CT is far inferior to MRI. If you take a ischemic stroke, better go for MRI.
Even in the protocol given by Harrison,
CT is enough to thrombolyze the patient. That is, even if in the most AHA guidelines, CT is enough. CT and RBS are the only two investigations to thrombolyze the patient. If the CT is not showing a large infarct, no bleed, the aspect scoring is there. That is less than 1/3 of the MC territories involved. You can safely thrombolyze. Nobody will question you. So you can even a stroke mix. I have thrombolized multiple stroke, postictal weakness. I have thrombolized. You should not miss this thing. Tumors or vascular malformations. That will be catastrophic. So the CT has a disadvantage that this vascular malformation. If in the periphery, the CT is good enough to look for the thrombolysis. Just to rule out the bleed.
Plain CT or CT with angio?
CT with angio is the best. For vessel, 4 piece you have to always rule out. CT with CT angio. But for thrombolysis, CT is enough, they say. Sir?
Is that guideline still there? Because many TAA can be thrombolized.
TAA, it is not a sin that we thrombolyze a TAA. Even if a patient comes to the casualty, has a minor weakness, but the weakness is there, NHS is 1 or 2, you think that the patient can worsen. You can thrombolyze, no problem. If you don't thrombolyze, there is the problem. That's from my experience. This patient will come with minor deficit, and you tell the patient that, okay, minor deficit, it will not cause any harm. After 12 hours, he will worsen to have dense hemiparesis. Then they will ask, I brought you in the window period, why didn't you thrombolyze? That is the commonest problem. I have multiple patients coming 2 years, 3 years later, you didn't thrombolyze, why didn't you thrombolyze? Like that. So the newspapers and all the media are promoting the thrombolysis. So even if you thrombolyze a minor stroke and you get complication, it will not harm you. You are safe. So it is minor stroke or a TAA, if it is completely recovered, okay, you can wait. So if it's a minor stroke, then I usually thrombolyze. I will document it as a NIHS 4 or 5. Even if it is a minor deficit, then I will thrombolyze. So minor strokes are very unlikely to bleed. So if you keep the BP controlled, it's very unlikely to bleed.
Sir, nowadays young strokes are very common.
Yes, sir.
Sir, mainly because of the binge drinking alcohol and
Yes, sir.
the patent foramen ovale. And
Yes,
now
sir.
being a cardiologist, I always focus on the
PFO,
PFO or small ASD.
Yes,
Or
sir.
quality echo is important, mandatory. And
yes,
the youngsters, especially in the third decade, invariably they will be hypertensive. LA also will be on the larger side, paroxysmal atrial fibrillation. And apart from and people, those who are from Kerala, those who are working in Gulf, usually their hemoglobin level is also on the higher side. And apart from the other conventional things you will evaluate, like
Yes,
hyperhomocysteine and other things, or lipoprotein or inflammatory things. But what is your experience of when you thrombolyze, whether it is turning to be hemorrhagic?
Hemorrhagic, I had actually
in cardiology,
patients.
when they will say that when we thrombolyze, the infarct-related artery will become hemorrhagic and VSR will happen like that.
Yeah.
So ideally, after
I had
delayed
one
window
patient-
period, we will send it for late PCA only.
Yeah.
So what is your experience about the young stroke?
Young stroke.
We are always bothered.
Young stroke,
and always I feel neurologists should insist for bubble study, contrast echo is a must. Often it is getting non-colicky echoes. If we start
Yes,
depending
yes.
on that echo report, it is waste.
Yes.
And
Young stroke, always look for a cardiac source. That is very important. Paroxysmal atrial fibrillation. PFO, even if you demonstrate PFO, in the setting of an acute stroke with an DVT, that is significant. So, what is the guidelines is that PFO, if you find in a stroke, the hazard ratio is...
Sir, another doubt is if a cardiologist is not there, neurologist is not there, young infarct has come. CT has taken, obtained, multiple showers of embolism. Whether, like in cardiology, whether do you recommend, sir, to give antiplatelets as loading, or directly you can go with thrombolyze with actylase?
If the patient is within window period, if the CT is a good aspects or is not showing a large infarct, you can safely thrombolyze. Within the window period, if the scan is good, you can safely thrombolyze, no problem. Any other questions?
I think we'll end the session now. Thank you, sir, for the
Thank you. Thank you, Amutha.
Thank you, Dr. Sesh, sir, for that enlightening session. Now I invite the chairs to hand over the memento to the speaker, Dr. Sesh Shivadasan, sir. Invite Dr. Binu Ramesh sir, Senior Consultant Cardiologist, ESI Hospital Kollam, to hand over a token of our appreciation to Dr. Ajay Kumar sir. We now call upon Dr. P.R. Rajiv sir, Consultant Physician, Pathfinder Diagnostic Solutions, Patanapuram, to present a gift to Dr. Amod sir.
Often missed, often masked, it tiptoes through the body with fatigue, weight gain, and forgotten warmth. It is a master of disguise, yet its impact is profound, affecting the rhythm of life, from heartbeats to hormones. Hypothyroidism is one of the most commonly encountered endocrine disorders in clinical practice. Yet, its manifestations can be subtle, varied, and often overlooked. Our next session is the silent slowdown, clinical pulse and practice extensions in hypothyroidism. For chairing this session, we have Dr. C. Rajshekharan sir, our respected head, Department of General Medicine, whose leadership and clinical acumen continue to inspire all of us, and Dr. Prabhas sir, Head, Department of Psychiatry, who has an extensive experience in the field of mental health and has made significant contributions in both clinical practice and academic teaching. To walk us through the nuances of this topic, we have with us our very own vibrant and dynamic physician, Dr. Ijaz Muhammad sir, Assistant Professor, AZEEZIA Medical College.
So, dignitaries on the dais and off the dais, and my dear friends, a very warm good morning to one and all. So, the topic, you know, the silent slowdown about the hypothyroidism. So, before going to the topic, why I choose the topic as hypothyroidism? Because I think you all know hypothyroidism is among the second most endocrine disorder we, not only the physicians, all the department doctors used to face, other than the type 2 diabetes. And the studies over the last 10 decades suggest that 1 in 10 adults in India suffer from hypothyroidism, and mainly adults in the age group more than 35 are at the risk of development of hypothyroidism. And hypothyroidism is 3 times more common in women, so you have to deal especially about the hypothyroidism in pregnancy. And 1/3 of the hypothyroid patients are unaware of their condition, and they will note it down when they have some silent slowdown in the physical quality of life. And in every 3 diabetic patients could have underlying a thyroid disorder. So in this scenario, I would like to, I selected the topic, the hypothyroidism as a silent slowdown. Into the topic. So everything needs an introduction, right? So from the basics, little words about the anatomy. This is one of the largest endocrine glands, which is situated just anterior to the trachea, and it weighs 15 to 20 milligram, and it's having 2 lobes joined by isthmus, and each lobe is 2 to 2.5 centimeter thick and wide. And when compared to the kidney, it's having double the blood flow. If the kidney is having 3 milliliter per minute per gram blood flow, the thyroid is having the blood flow of 4 to 6 milliliter per minute per gram. Some words about the physiology, I think all know this. So normally we have the hypothalamus, which releases the thyroid releasing hormone to the pituitary. It gets stimulated and release the thyroid stimulating hormone, which turns on the thyroid gland and release the thyroid hormone. So what happens in hypothyroidism? We have the primary and secondary. So in primary hypothyroidism, the pathology lies in the thyroid gland. So there will be sufficient TSH released from the pituitary, but the diseased thyroid gland is not able to release the thyroxine. As a result, in primary hypothyroidism, the TSH value will be high, but the thyroid is not able to form the thyroxine, so the T4 will be low. And in case of secondary hypothyroidism, that is the pathology other than the thyroid gland, it may be in pituitary or in the hypothalamus, there will be deficiency of thyroid stimulating hormone from the pituitary or from the hypothalamus, and it is not sufficient to activate the thyroid gland, so the TSH will be low, and at the same time T4 will be also low. So why in So briefly about the T3 and T4 pharmacology. We have the thyroxine T4 and the tetrahydrothyronin T3. So thyroxine, the half-life is 7 days. Why I'm stressing that? It is having a very vast importance in the daily practice. We will discuss it later. And it is stable and long-acting. And the intestinal absorption of oral T4 is around 80%. That means it is having a very high bioavailability. About the T3, its half-life is only 0.75 days. That is 3/4 of a day. The onset of action is 2 to 4 hours. It is rapidly absorbed, and the external administration of thyroxine can cause marked blood level fluctuations and may falsely suppress the TSH if taken close to the blood work. So very few details about the thyroid function test. We have the thyroid stimulating hormone TSH, total T4, total T3, free T4 and free T3. And the free T3 and T4, it is nothing but they are the unbound form of thyroid hormone, which is not bound to the thyroid albumin or globulin. And we have 2 values, standard range and functional range. So in the blood investigation reports, we used to see the standard range of TSH as, taking the TSH as an example, we will see it as 0.4 to 5, but the functional range is 1.4 to 2.2. So the functional range, it is nothing but, if you are treating the patient, we better to keep the range of the TSH as the functional range, that is 1.4 to 2.2. So moving to the hypothyroidism, we have the primary hypothyroidism, secondary and the transient thyroidism. So comparing the primary and secondary, 99% of primary hypothyroidism, 99% is of primary and only about 1% is of secondary hypothyroidism. So few causes about the primary hypothyroidism. I think the students can note it down because definitely they will get a question for hypothyroidism either in the essay or short note. So it can be autoimmune hypothyroidism, which constitutes about, which includes Hashimoto thyroiditis and atrophic thyroiditis. So what happens in Hashimoto and atrophic thyroiditis, it is an autoimmune entity. So when autoimmune destruction starts, in the initial phase, the TSH will be low, TSH will be normal, and the T4 will be also normal, and the patient will be asymptomatic. But when the disease progresses, there will be slight elevation in the TSH, and there can be elevation or the T4 can be normal. And it can be defined as subclinical hypothyroidism or can be Hashimoto thyroiditis. And in that condition, we will be getting the goiter. But the disease advance or the autoimmune destruction completes, there will be marked level of TSH hormones with low T3 and T4. That is known as atrophic thyroiditis. And in that condition, the organ will be atrophied. And we have other causes like iatrogenic with the iodine treatment, subtotal or total thyroidectomy, external irradiation of neck for lymphoma. These causes are reversible. And the drugs, we have the iodine, and we all know amiodarone, and lithium, antithyroid drugs, para-aminosalicylic acid, interferon alpha, and other cytokines. Then we have the congenital hypothyroidism among the primary cause. Then iodine deficiency, infiltrative disorders like amyloidosis, sarcoidosis, hemochromatosis, scleroderma, cystinosis, riddle thyroiditis, and the overexpression of type 3 deiodinase in infantile hemangioma can cause, and other tumors can cause primary hypothyroidism. And about the secondary hypothyroidism, we know the thyroid will be normal, the pathology will be in either pituitary or hypothalamus. So hypopituitarism, tumors like tumors in the pituitary, then pituitary surgery or irradiation, infiltrative disorders, Sheehan syndrome, trauma, Jennings forms of combined pituitary hormone deficiency, isolated TSH deficiency, bexarotene treatment, it is one of the newer chemotherapeutic agent, and hypothalamic disease like tumors, trauma, infiltrative disorders, and idiopathic. Causes can be the causes of secondary. And we have some causes for transient hypothyroidism, because after some time it is reversible and thyroid function will be normal. Among the transient hypothyroidism, we have the silent thyroiditis, including postpartum thyroiditis, subacute thyroiditis, the withdrawal of supraphysiologic thyroxine treatment in individuals with an intact thyroid. So these are the causes of primary, secondary, and transient. And remember, again, the primary constitute about 99% of hypothyroidism. Yes, about the primary hypothyroidism we have already discussed. The pathology lies in the thyroid gland, and the thyroid gland is not able to produce the thyroxine. And the thyroid peroxidase antibodies are elevated in majority of patients with chronic autoimmune thyroiditis. Almost 95% with chronic autoimmune thyroiditis, the anti-TPO will be positive. So what are the signs and symptoms? Based on this, we have given the title as the silent slowdown. Definitely, most of the patient will be asymptomatic. It will be an incidental finding. But the patient with symptoms, it can be tiredness and weakness. There will be dry skin. And as a sign, we can see dry, coarse skin, cool peripheral extremities with decreased sweating. And there can be dryness of the, some dryness of the skin layers. And there will be feeling of coldness. Then there can be hair loss, where the patient will be having diffuse alopecia. And in the signs we have puffy face, hands, feet, and mixed edema. So what happens is, in thyroid, we will be having non-pitting edema because it is due to the accumulation of glycose aminoglycans, which pull out the, because of the presence of the glycosaminoglycans, we will be having puffy face, hands and feet, and non-pitting edema. Then there will be difficulty in concentrating and poor memory. Patient will be having constipation, weight gain with poor appetite, dyspnea, hoarseness of voice, menorrhagia, paresthesia, and impaired hearing. Then again, as a signs, there will be diffuse alopecia, and we can see bradycardia with diastolic hypertension. So if you are able to see any patient with bradycardia and diastolic hypertension, and if the age of the patient is more than 35, definitely you have to evaluate for thyroid. And there will be delayed tendon reflex, and some patient will be having carpal tunnel syndrome, and with the activity of glycosaminoglycans, there will be serous activity effusions. And the hoarseness of voice is again due to the accumulation of glycosaminoglycans in the laryngeal cavity or in the vocal cord. So when considering all these signs and symptoms, this will definitely slow down the physical activity of an individual. So that's why we entitled the topic as the silent slowdown. So briefly about the lab evaluation of hypothyroidism, we all know we will measure the TSH. If it is elevated, we will measure the unbound T4. If it is normal, if it is low, we will take it as if the measure unbound T4 is low, we will take it as primary hypothyroidism. And if you are taking it as primary hypothyroidism, you have to send for the thyroid peroxidase antibody. If it is positive, it is autoimmune hypothyroidism, and definitely the treatment is T4. Then TPO antibody is negative, you have to rule out the other causes of hypothyroidism. So the measure unbound T4 is normal, we can take it as mild hypothyroidism. Again, we have to send for the thyroid peroxidase antibody. So if it is positive and the patient is symptomatic, we have to consider the thyroxine as a treatment. And if the thyroid peroxide oxidase antibody with no symptoms, we can send the patient with a reassurance and advice of annual follow-up of TSH. So if the measured TSH is normal and we are having some suspicion of the suppression of the pituitary, if there is no suspicion, well and good, no further test. But if you are having the suspicion of a pituitary disease, you should measure the unbound T4. If it is low, you should rule out the drug effects, sick youth thyroid syndrome, then evaluate anterior pituitary function, and if it is normal, no further test. So, few words about the sick euthyroid or non-illness thyroid, previously called as sick euthyroid. So, we don't prefer to send the thyroid values in a patient with acute illness because it can give false values. We can see the TSH and T4 as low values. In the upper border of the lower value, we can see TSH and T4 with lower value. So we don't prefer to send the TSH values in a patient with acute illness. So this is about the lab evaluation of hypothyroidism. Then the main part, the treatment. So we all know, whatever the case, the treatment will be thyroxine, T4. And the best part is that the thyroid is very easy to diagnose and it is gratifying to treat because we will get a complete response. Because with the physicians, we can heal the disease with so many investigation. It will take time. Unless like ortho or surgery, it will take time. But in the case of thyroid, we can diagnose easily and we can get a complete response with a simple drug. So the primary goal is to normalize the TSH and the treatment always with levothyroxine, that is T4, LT4. So the primary advantage of levothyroxine is that the body has a mechanism that when considering the T3 and T4, the T4 will be around 80% and T3 will be only up to 20%. So the primary advantage of T4 is that there will be, whenever the body needs T3, there will be deiodination from the T4, which is around 80%. So the physiological primary deiodination mechanism can produce T3 as required in the tissue under normal physiological control. Even there are some controversy about giving directly T3. There is evidence studies. Studies are evident that we should give levothyroxine as a treatment. So the full replacement dose usually about 1.6 microgram per kilogram of lean body weight. Lean body weight means we should exclude the fat. So the weightage is 1.6 microgram per kilogram of lean body weight, and it should not be adjusted upward in the obese individuals. And absorption is more complete and less erratic in fasting state. I think the PGs and house surgeons, you will be aware that we used to write the prescription that Thyronome or Thyroxine 100 in the early morning in the empty stomach. That means absorption is more complete and less erratic in fasting state, and it is having interaction with some other foods and drugs. And patients are advised to take, we can safely take with next day dose. So if any individual missed 1 day dose, we can advise them to take the double dose on the next day. For example, if one is taking a tablet of 75 and unfortunately he missed the dose, we can safely advise the patient to take 150 on the next day, because the half-life is 7 days, so that it can replenish the TSH values. And some patients do not need full replacement at first. So never wrong to start low and titrate up. Even the if you calculate with the 1.6 microgram per kilogram, we will get in some patients we will get at a high dose. But some patients do not need full replacement, so never wrong to start low dose, and we can titrate up. And we should be careful in CAD elderly. You should start with lower dose, 25 to 50 microgram per day, because about the over treatment, one side effect is atrial fibrillation, and the other one is it will decrease the bone mineral density. So we should be cautious in patients with coronary artery disease, and you should avoid taking with iron, calcium, which impairs the absorption of levothyroxine. And we can titrate the dose up to normalize the TSH, and you should recheck 6 to 8 weeks after dose changes and 6 to 12 months thereafter. So definitely a question will come, when the symptoms will be relieved. So you should know that there will be relief of symptoms after 3 to 6 months of the normalization of the TSH. Only after 3 to 6 months after the normalization of the TSH, there will be symptom relief. So there are some conditions requiring dose adjustment. So the conditions with increased dose requirement, that is condition with decreased intestinal absorption of T4. We have the patients with increased dietary fiber supplements, those with reduced gastric acid secretion or having H. pylori infection, atrophic gastritis, or frequently taking proton pump inhibitors. Then in case of malabsorption like celiac disease, short bowel syndrome, lactose intolerance, bariatric surgery, bile acid sequestrants, and agents that bind levothyroxine like sucralfate, aluminum hydroxide, ferrous sulfate, calcium carbonate, and sevelamer. So we know that definitely the patient will be having tiredness, and at the same time we used to give, definitely most of us will be giving some Neuravine Fort, or the patient simultaneously will be having vitamin D deficiency, so we will be giving cell calcity or a calcium vitamin D supplement. So we should be cautious that should be never given with calcium and iron. And there are some conditions with increased need for T4, that is the patient is having weight gain, then estrogen and pregnancy. And there is increased metabolic clearance, condition with increased metabolic clearance of T4, those with anti-epileptic drugs like phenobarbital, phenytoin, carbamazepine, and those taking tuberculostatic drugs like rifampicin. And there are some conditions with decreased dose requirement, that is you should decrease the need for T4 in the case of weight loss or androgens, and decrease metabolic clearance of T4 in the case of old age. So a few words about the subclinical hypothyroidism. We all will be having doubt that when to start the treatment, whether to start treatment, when to start treatment, when to assess the patient. So it is defined as elevated serum thyrotropin or TSH level with normal levels of free thyroxine, and it affects up to 10% of the adult population. It is most often caused by autoimmune, that is Hashimoto thyroiditis, and there is a greater risk of progression from subclinical to overt hypothyroidism in patients with circulating thyroid peroxidase antibodies. So based on the TPO antibodies and the age and the symptom, we will go for the treatment. So it may be associated with an increased risk of heart failure, coronary artery disease events, and mortality from coronary artery disease. And the patient may have cognitive impairment, fatigue, and altered mood. And there is no evidence it is beneficial to treat the person aged 65 years or older. And and the treatment usually indicated for patients with subclinical hypothyroidism and serum TSH level, which is more than 10 milliunit per liter. So, how you proceed with the treatment for a subclinical hypothyroidism? So, if the TSH value is 4.5 to 6.9, and you should, the patient age is less than 65, you should measure the TP antibodies, follow the TSH measurement in the asymptomatic patient, and you should consider the treatment if there is plan for pregnancy, significant hypothyroid symptoms, positive TP antibodies, and if the patient is having goiter. And if the patient age is more than 65, there is no need for treatment. If the TSH value is 7.7 to 9.9, definitely you should treat with levothyroxine. If the age is less than 65, you should treat with levothyroxine. And if the patient's age is more than 65, again, you can consider treatment with levothyroxine. Treatment will be always levothyroxine. If the TSH is more than 10, treat with levothyroxine. Even if the age is more than 65, you can treat with levothyroxine. So few words about hypothyroidism in pregnancy, because it's more common in women. So we should have a look on the hypothyroidism in pregnancy. So the disease burden is worldwide, it's around 1.5 to 4%, and in India it's about 11%. And it's based on trimester specific TSH cutoff. We have trimester specific TSH cutoff. So in the first trimester, the cutoff should be, the upper limit of TSH should be 2.5. In the second trimester, it should be 3, and the third trimester, again, it should be 3. And what are the risk factors of hypothyroidism in pregnancy? Maternal risk factors like anemia, gestational hypertension, abruptio placenta, postpartum hemorrhage and abortion, and fetal and neonatal risk like preterm birth, low birth weight, respiratory distress, and neurocognitive impairment, or can have congenital hypothyroidism. So how will you approach your case of thyroidism in pregnancy? You screen at the first antenatal visit, and you should send for the FT4, TSH, and anti-TPO. If free T4, TSH is normal and anti-TPO is negative, no treatment is required, and review as when clinically indicated. And if free T4, TSH is normal, but the TPO is TPO antibody is positive in a pregnant woman, you should observe the patient, monitor with TSH at least once in every trimester and at least up to second trimester. And you can consider low dose levothyroxine in euthyroid pregnant woman who is TPO antibody with a history of pregnancy loss. And if the T4 is normal, TSH is more than 2.5, you should consider the levothyroxine as a treatment. And if the patient is having overt hypothyroidism, TSH is high and with the symptoms, and irrespective of TPO, you should give the treatment with levothyroxine. Actually, I would like to stress a few words about congenital hypothyroidism with the support of our pediatrics. Unfortunately, I think I am not able to see one of them. So we'll skip the congenital hypothyroidism. So about the central hypothyroidism, we have already discussed. The pathology lies in the pituitary or in the hypothalamus. And the central hypothyroidism, TSH will be low, means TSH will be there, but it is only immunoactive but no bioactive. So that's why we are getting low TSH in case of central hypothyroidism. So I would like to conclude the session with some take-home message. 1 in 10 adults in India has hypothyroidism, and the treatment is almost always with levothyroxine, that is LT4, with a total replacement dose is 1.6 microgram per kilogram per day with lean body weight. And you should start with a low dose, 12.5 to 50 microgram day in an elderly, and with a suspicion of the risk of atrial fibrillation or coronary artery disease. And levothyroxine should be taken ideally 40 minutes before food and 4 hours prior or after the drugs that alter serum concentration. And TSH should be monitored at least 8 weeks after titrating the dose, because TSH, it will take definitely more than 6 weeks. So if you are having some clinical suspicions or difference, you can send for the T4, because it can be normalized within 4 or 5 weeks, but TSH, it definitely takes more than 6 weeks for the normalization or any improvement. And the preconception and the first trimester, you should keep the TSH below the value of 2.5. So that's all about the topic. Thanks for the patient listening. Thank you.
Thank you, Dr. Jas, for the compact but yet comprehensive presentation. And yes, I just want to ask one question, and to the positive time, we'll limit the questions. And what's the relationship between NASH and hypothyroidism?
NASH, there is an association with dyslipidemia and hypothyroidism because reduced TSH level or hypothyroidism, they can increase the LDL receptors. At the same time, it can increase the activity of HMG coenzyme A reductase enzyme. So it can increase the risk of dyslipidemia. So if you are getting a patient at the age of 35 or more with dyslipidemia, definitely you should go for screening the hypothyroidism before starting the statins or any other supplements. Thanks.
Say, Doctor, it was a nice presentation.
Thank you, sir.
And I would like to ask only one question, because I got a doubt. Lithium, you told that definitely it causes hypothyroidism. So, if the TSH level is high and the patient is on lithium, will you start this thyroxine tablet or some other else?
So lithium, you all know, we have discussed about some drugs, but the most common is lithium and amiodarone, which is excess in iodine. So lithium, what happens is, it can decrease the production of T3 and T4, which can disrupt the release of T3 and T4, and it can even interfere with binding of thyroglobulin. So if the patient is having, I think, sir, we give lithium for the bipolar disorder. So if the patient is taking lithium and patient is hypothyroid, if the patient is, we can alter the dose or increase the medication dose in two scenarios. If the patient is having refractory hypothyroidism, even giving the lithium, the patient is, refractory mood disorder. Even after giving the lithium, if the patient is having mood disorder, the thyroid disorder can be one of the predisposing factor. So you can increase the thyroid dose. And if the patient, even the patient is having subclinical hypothyroidism with mood disorder, it can be one predisposing factor. That is one scenario. And if the patient is having overt or clinical hypothyroidism, definitely you should start the treatment with levothyroxine. No need to stop the lithium, because I think Sir can explain more about the bipolar disorder. So you can continue the lithium along with the thyroxine supplementation.
Thank you.
So, any questions from the house? Any more questions? I think a couple of questions in order. Well, if there are no questions, I think we will conclude the session because of the paucity of time. Thank you, Dr. Ijas. Thank you very much.
Thank you.
Thank you, Dr. Ija, sir, for that well-structured and insightful talk. Now, I invite the chairs to hand over the memento and certificate to the speaker, Dr. Ija, sir. We now call upon Dr. K.N. Prasad, sir, Consultant Physician, Holy Cross Hospital, Kottayam, to hand over a token of gratitude to our Dr. Rajshekharan, sir. Also, I like to call upon Dr. Sijo John, Consultant Physician, LMS Hospital, Kundara, to hand over a token of gratitude to Dr. Prabhas, sir.
Ladies and gentlemen, we now officially move forward with the inaugural session of ADAMCOM 3. It is now my honor to invite our respected chief guest of honor, our Honorable Director, Dr. Anas Aziz Sir, our beloved Principal, Dr. K. Shashikala Ma'am, Dr. C. Rajashekharan Sir, Head of Department General Medicine, Dr. K. Srikathan Sir, Professor, Department of General Medicine, and our beloved Professor, Dr. Shashidharan Sir, to the dais. We now invite Dr. Rajashekharan Sir, Head, Department of General Medicine, to deliver the welcome address.
Respected dignitaries on and off the dais, our respected Director, Dr. Anas Sir, Cecilia Madam, Shesh Sir, Dr. Prabhash, Sriyan Sir. It gives me immense pleasure to welcome you all to the third edition of ADAMCOM, a confluence of minds, hearts, and hearts committed to the art of science of medicine. This year, our theme was Science Behind the Symptoms, Decoding the Disease from Bench to Bedside, which captures the every essence of the clinical medicine. It reflects our collective journey as physicians and researchers in translating complex biomedical insights into a compassionate, patient-centered care. We are honored to have our host of distinguished speakers, young innovators and dedicated clinicians, each bringing their unique perspective to this important event. Over the next few hours, let's engage deeply, question freely, and learn generously. Before we begin, let us take a moment to remember and honor the visionary behind our institution, our beloved chairman, Sri Abdul Aziz Sir. His foresight, dedication, and unwavering commitment has laid a strong foundation upon which this institution stands today. We are also privileged to have with us the pillars of our institution, our beloved directors, Dr. Anas Aziz, Ansar Aziz, Dr. Hassan Aziz, and Dr. Hashim Aziz, and Dr. Mirza Aziz. And Anas sir is here with us, and I welcome you, sir, onto the stage. Now, their dynamic leadership and tireless efforts and forward thinking has been instrumental in transforming the institution into a center of excellence. Now, their support for the programs of ADAMCOM reflects their enduring commitment to fostering the culture and continuous learning innovation. Now, I extend my warm welcome to our respected principal, Cecilia Madam, whose constant guidance and support nurture both academic and administrative excellence. Now, it's indeed our privilege to have among us Professor Emeritus Dr. Sriyan Sir, the mentor whose legacy in medical education continues to inspire generations. Sir. We are equally honored to welcome our consultant physician, Dr. Shashidharan, whose contributions to the field of medicine and patient care have left us an indelible mark. Now, another person to be welcome to the stage is Dr. Prabhash, consultant physician, my classmate and psychiatrist. Yeah, I welcome you, Dr. Prabhash, to the stage. Now, on behalf of the organizing committee of our institution, I welcome you all once again and look forward to the rich exchange of ideas which lie ahead. Let us today be a celebration of ideas, collaboration, and professional growth as we explore new dimensions of clinical medicine together. Once again, welcome to ADAMCOM. Thank you.
Thank you, sir. We now invite our respected director and consultant pediatrician, Dr. Anas Aziz, sir, to inaugurate the function and deliver the inaugural address.
Respected Dr. Shashikala Madam, Dr. Rajesh Sir, HOD, General Medicine, Dr. Srigandan Sir, Dr. Shashidharan, and Dr. Prabhat Sir, other dignitaries on the dais, and invited delegates, my dear staff and students. It's a real pleasure to be here with all of you today. And I am genuinely happy to attend this year's ADAMCON CME, organized by our Department of General Medicine. It's wonderful to see so many respected and experienced doctors gathered here from Kollam, near and far, to share the knowledge and learn together. This year's theme, Science Behind the Symptoms. It is a powerful one. As doctors, we all know that symptoms are just the beginning. What really matters is understanding what's happening beneath the surface. This CME is a great chance to explore that in more depth, to challenge our thinking, and to stay up to date with what medical science has to offer. I want to give a heartfelt thanks to our Dr. Rajashekharan sir, our HOD, for his vision and dedication. He is someone who always leads by example, with humility, hard work, and a real love for medicine. His tireless efforts, along with the hard work of his dedicated team of physicians, Dr. Srigandan sir, Dr. Shashidharan sir, Dr. Amit, Dr. Anil Vijayumar, Dr. Ijaz, Dr. Reshma, Dr. Bibin, and all other faculties who have created a platform for a meaningful learning and collaboration. I'm sure today's session will spark some great discussions and give us fresh insights to take back to our own practice. Let's make the most of it, listen, ask questions, share ideas, and most importantly, keep that spark of curiosity alive. With that, I am happy and honored to declare ADAMCON 2025 officially inaugurated. Thank you.
Thank you, sir. Now, we invite our beloved principal, Dr. K. Shashikala ma'am, for a facilitating address.
ബഹുമാനപ്പെട്ട ഡയറക്ടർ അനസ് സർ, Head of the Department of General Medicine, Rajeshekharan sir, Emeritus Professor Srigandan sir, Psychiatry, Department of Psychiatry, Head of the Department Prabhat sir, Internal Medicine, Assistant Professor Dr. Shashidharan, സദസ്സിൽ ഉള്ള ബഹുമാനപ്പെട്ട delegates, other dignitaries, my dear children. In the initial phase, I have a small request to the students who are attending the conference to be silent, as their murmuring is creating a lot of confusion and irritation to the audience. So if you want to attend, you can sit there quietly and to attend. Or if you don't want to attend, you please leave the session. Because your murmuring it is too difficult for us to attend the talk of Dr. Ijaz. So please be silent and listen to the conference, because in the conference you are getting, or in the CME you are getting a lot of inputs from learned resource persons. That's why the students are asked to attend the CME, because you will get immense knowledge apart from your textbooks as well as apart from your classes. Now I am coming back to my duty. As the principal, I am immensely thankful to the Department of General Medicine for organizing ADAMCOM 3 this year, but they are so eagerly organizing conferences yearly. When I joined here in 2022, this is the third one. Yearly they used to organize one conference, that too an elegant one. So I am extremely thankful to them as the principal. And their academic dedication is also it's an excellent one, and it gives us an input. Its input is very good, and we are getting an excellent result last year and the other year also. Last year we have around 96% pass in the general medicine. That is because of their dedication. And I request, in presence of director I am telling, I request many of the departments to organize at least one CME, that we have to do something, sir. And actually the Department of General Medicine is the one that yearly organizes one CME, and this is the third one. And their topic selection is also excellent, because it will give an understanding as well as some recent knowledge in the very important day-to-day seen cases. And this time also, the only one I hear is the one that had been presented by Dr. Ijaz, that is on hypothyroidism, and that's an important thing as far as a patient is concerned, and the patient load is also very high, and the prevalence is also very high. So such topic selection is also very, very important, and the medicine department is excellent in selecting ideal topics that are of clinical importance. And I extend my gratitude as well as my best wishes to the Department of Medicine for organizing this one, and also to the success of the conference. Thank you.
Thank you, madam. Now we invite Dr. K. Srikathan, sir, to address the gathering.
Good morning to all. Respected Director Dr. Anas, respected Principal Dr. Asigala Madam, respected Professor of Medicine Dr. Rajasekharan, Dr. Sasitharan, Assistant Professor Department of Medicine, and Dr. Prabhas, Professor of Psychiatry. Good morning everyone. I am honored to be here today to offer a felicitation speech for this valuable CME event, ADAMCOM 25. This is the third CME being conducted by the Department of Medicine yearly. We owe a great debt to the gratitude to our esteemed speakers for sharing their expertise with us. We also want to express my sincere appreciation to the organizing committee for this tireless effort in making this event a resounding success. And all of you are attendants, thank you for taking the home to invest in your professional development. I am confident that the knowledge and the skills you gain will make the real difference in your practice. Let us all take this opportunity to not only appreciate the knowledge we have gained, but to actively apply it to our daily routine. May the CME event serve as a catalyst for growth and innovation within our profession. Thank all of you for being here and congratulate on this successful event. Thank you all.
Thank you, sir. Now we invite Dr. Prakash sir for a facilitation speech.
വേദിയിലും സദസ്സിലും ഇരിക്കുന്ന മഹത് വ്യക്തികളെ, ഡോക്ടർ രാജശേഖരൻ പറഞ്ഞ കണക്ക് ഞങ്ങളൊരു 50 കൊല്ലം മുമ്പ് ക്ലാസ്മേറ്റ്സ് ആയിരുന്ന ആ സമയത്ത് ഇതുമാതിരി ഒത്തിരി CMEs കണ്ടക്ട് ചെയ്തിട്ടുണ്ടായിരുന്നു. അദ്ദേഹം ഈ പ്രിൻസിപ്പൽ മാഡം പറഞ്ഞ കണക്ക് നല്ലൊരു ഓർഗനൈസറായിരുന്നു. അന്ന് ഈ CME കോൺഫറൻസിൽ ഇരിക്കുന്ന ആരും ഒരു ചെറിയ വാക്ക് പോലും അങ്ങോട്ടും പരസ്പരം ഇങ്ങോട്ടും സംസാരിക്കത്തില്ലായിരുന്നു. ഡൗട്ട്സ് മാത്രമേ ചോദിക്കത്തുള്ളായിരുന്നു. അതും ഈ സ്പീക്കറുടെ അടുത്ത് പരസ്പരം അങ്ങോട്ടും ഇങ്ങോട്ടും സംസാരിക്കുന്ന പ്രശ്നമേ ഇല്ല. ദയവേത് അക്കാര്യം ഭാവിയിൽ ഓർത്താൽ വളരെ നല്ലതായിരിക്കും. പിന്നെ ഡോക്ടർ രാജശേഖരൻ ഈ പറഞ്ഞ കണക്ക് നല്ലൊരു ഓർഗനൈസറാണ്. ഞങ്ങൾ 76 ഒത്ത് MBBS പഠിച്ച ആൾക്കാരാണ്. ആ സമയത്ത് മിക്കവാറും CMEകളൊക്കെ അദ്ദേഹം ഓർഗനൈസ് ചെയ്തിട്ടുണ്ട്. മാത്രമല്ല ഒരു സ്റ്റുഡിയസ് സ്റ്റുഡൻ്റ് എന്ന് മാത്രമല്ല, ഹി വാസ് എ സ്പോർട്സ് മാൻ, ക്രിക്കറ്റ് മാൻ ആൻഡ് കൂൾ ക്യാപ്റ്റൻ എന്ന് പറയുന്നൊരു ക്യാപ്റ്റനായിരുന്നു അദ്ദേഹം. അന്ന് ക്യാപ്റ്റനായിരിക്കുമ്പോഴത്തേക്ക് നമ്മുടെ കാലിക്കറ്റും തമ്മിലുള്ള മത്സരമാണ് ഇൻ്റർ മെഡിക്കോസ് ക്രിക്കറ്റ് മാച്ച്. അതിൽ ഫസ്റ്റ് സ്ലിപ്പിൽ എന്നെ പിടിച്ച് നിർത്തി. അദ്ദേഹം ബൗൾ ചെയ്ത് കഴിഞ്ഞിട്ട് കാലിക്കറ്റിൽ ഒരു നല്ലൊരു ബാറ്റ്സ്മാൻ സ്മൂത്തായിട്ട് അദ്ദേഹത്തെ ഔട്ടാക്കിയാൽ ഞങ്ങൾ ജയിച്ചു എന്നുള്ള ലെവലിലായി. ആ ക്യാച്ച് എന്നെ എടുക്കാൻ പറ്റി, പക്ഷേ എൻ്റെ ഒരു പല്ല് പോയി. ബാക്കി എല്ലാവരും കൈയടിച്ച് രസിച്ചപ്പോഴേ ക്യാപ്റ്റൻ എൻ്റെ അടുത്തോട്ട് വന്ന് പല്ലെങ്ങനെ കൊണ്ട് മാറ്റം പ്രശ്നമെന്ന് പറഞ്ഞ് എന്നെ ഫസ്റ്റ് എയ്ഡൊക്കെ തന്ന് പിടിച്ച് നിർത്തുകയായിരുന്നു. അപ്പോൾ ഒരു ക്യാപ്റ്റൻസിയുടെ റോള് അന്നും അദ്ദേഹത്തിനുണ്ടായിരുന്നു. ലീഡർഷിപ്പ് ക്വാളിറ്റി അതുപോലെ ഉണ്ടായിരുന്നു. മാത്രമല്ല അദ്ദേഹം നല്ലൊരു കവിയാണ്, പോയറ്റാണ്. ഇപ്പോഴും കവിതകളൊക്കെ ഒത്തിരി എഴുതുന്നുണ്ട്. അത് പലർക്കും അറിയത്തില്ലായിരിക്കാം. അതുകൊണ്ട് നല്ലൊരു അക്കാഡമിഷ്യനാണ്, നല്ലൊരു സ്റ്റുഡിയോ സ്റ്റുഡൻ്റാണ്. എല്ലാം കൊണ്ടും എല്ലാ സകലവല്ലഭനാണ്. അദ്ദേഹത്തിൻ്റെ കീഴിൽ നിങ്ങൾ അക്കാഡമിക്സ് കിട്ടിയത് വളരെ ഭാഗ്യമെന്ന് പറയട്ടെ. അതുപോലെ നല്ലൊരു പ്രിൻസിപ്പൽ മാഡം നമുക്ക് കിട്ടിയിട്ടുണ്ട്. എല്ലാ കാര്യത്തിലും ജാഗരൂകയായിരുന്നുകൊണ്ട് അപ്പോഴപ്പോഴുള്ള ഇൻസ്ട്രക്ഷൻ നമുക്ക് തന്നുകൊണ്ടുള്ള പോകുന്ന ഒരു വ്യക്തിയായിരുന്നു. അതിന് വ്യക്തിയോട് ആ മാഡത്തിന് പ്രത്യേകം അഭിനന്ദനങ്ങൾ പലപ്പോഴും ഇതുണ്ട്. മാഡം പലപ്പോഴും പല കാര്യങ്ങളും ഫോണിൽ കൂടെ ചോദിക്കാറുണ്ടായിരുന്നു. പിന്നെ ഡയറക്ടർ, ഓഫ് കോഴ്സ് ഞാൻ പറയേണ്ട കാര്യമില്ല, എനിക്ക് മുമ്പേ തന്നെ അറിയാം എന്ത് കാര്യത്തിനും നമ്മളോട് സഹകരിച്ചു പോകുന്ന ഡയറക്ടർഷിപ്പായിരുന്നു. അപ്പോൾ എല്ലാ കൊല്ലവും അടുത്ത കൊല്ലവും ഇത് 2ാമത്തെ സെഷനാണ് ഞാൻ അറ്റൻഡ് ചെയ്യുന്നത്. അടുത്ത കൊല്ലവും ഇതുമാതിരി ADAMCOM അറ്റൻഡ് ചെയ്യാനായിട്ട് മുകളിലിരിക്കുന്ന ജഗദീശ്വരൻ എനിക്ക് ചാൻസ് തരട്ടെ എന്ന് ആഗ്രഹിച്ചുകൊണ്ട് നിർത്തട്ടെ. നന്ദി, നമസ്കാരം.
Thank you, sir. Now we request Dr. Shashidharan sir to deliver the vote of thanks.
Good morning to all my friends. And the vote of thanks is usually towards the last period of the talk, but due to some adjustments, I have been given the work, the duty to say the vote of thanks after 2 talks. First, I, on the behalf of my department, extend my sincere gratitude to the administrative people, especially Anas sir, for permitting us to conduct this program. And our principal, she was also very interested in our preparations, and she also gave valid instructions to us, and she was also with us. I also extend my heartfelt thanks to her. Then our senior-most person, Dr. Srikantan, sir came, and even the mere presence of sir is a great inspiration to us, and I extend my thanks to Sri Kandan sir also. And no academic program will be complete without the sincere talks, and we have speakers from guest speakers as well as speakers from our own hospital. I would like to congratulate them for their extreme work preparation to get to study the topic and present in a beautiful way, so that it will be increasing our wisdom. And so many pharma companies have helped us to conduct this ceremony. I would like to extend my gratitude to them also. So, sorry sir, I forgot about Rajshekharan sir. Rajshekharan sir, every year during March or April, he will have the idea to conduct the CME, and the whole program was conceived, planned, and executed by Dr. Rajshekharan sir and his PG friends, PG students. And I extend my gratitude to them also to making this process a great success. And the audio-visual team, they also have helped us a lot, and I extend my thanks to them also. And finally, I thank each and every person who is present here as members to hear our academic feast, and I believe that everybody will be a little wiser more when they leave the hospital. Thank you, sir.
Thank you, sir. Thank you, respected chief guests, for your inspiring words. With this, we conclude our inaugural function. We now proceed to our third scientific session, febrile neutropenia, addressing the basics. In the realm of clinical urgency, few conditions demand swifter attention. A quiet fever in a vulnerable host, it often masks a storm beneath. Today, we return to the roots to understand the basics, sharpen our instincts, and strengthen our responses. The session will guide us through the essentials that turn early suspicion into life-saving action. Chairing the session is Dr. K. Shashikala ma'am, Professor of Forensic Medicine and our esteemed principal. We invite ma'am to the dais. Delivering this session is Dr. Parvati Rajashekharan, Consultant Clinical Oncologist, Kakinos Healthcare, Trivandrum. I now invite Dr. Parvati ma'am to the stage.
Okay, good morning. So, before I begin, I would like to thank the organizing committee of ADAMCON for letting me a part of this event this year also. So, thank you, especially the Department of General Medicine of AZEEZIA Medical College. So, why febrile neutropenia? It's basically an oncological topic. Why it is important from a physician's perspective? Usually what happens is, these cancer patients, when they are on chemotherapy, when they have a fever, when they have a neutropenic episode, it is the physician who will be the first attending doctor. So mostly the patient will be presenting to a physician first. So it is of utmost importance that they know about the topic, not the management part, because the antibiotic part they'll be very well versed, but at least not to miss, what not to miss when a patient is presenting with febrile neutropenia. So I'll just begin. What is febrile neutropenia? Febrile neutropenia is defined as any single reading of oral temperature of more than 38.3 degrees Celsius or 2 consecutive readings of more than 38 degrees Celsius for a period of 2 hours in a patient with absolute neutrophil count of less than 500 or when the ANC is expected to fall below less than 500. So basically, in a patient on chemotherapy, when they have a febrile episode, when the count is less than, when the ANC is less than 500, when this patient has a single reading of more than 38.3 degrees Celsius or 2 consecutive readings of more than 38 degrees Celsius in over a period of 2 hours is what you call a febrile neutropenia. What is ANC? ANC is absolute neutrophil count. How do you calculate it? It is basically the percentage of neutrophils plus percentage of man forms into WBC count divided by 100. Now, depending on the grade depending on how low the count is, the neutropenia can be severe or profound. Severe neutropenia is when the ANC is less than 500 and profound neutropenia is when the ANC is less than 100. Now, again, depending on how bad the ANC count is, it has 4 grades. Grade 1 is ANC between 2000 to 1500. Grade 2 is ANC between 1500 to 1000. Grade 3 is when the absolute neutrophil count is between 1000 to 500. And grade 4 is when the absolute neutrophil count is less than 500. Now, how common is febrile neutropenia? It is associated with about 10 to 15% of solid tumors, and it is associated with the chemotherapy of almost more than 80% of hematological malignancies. Now, it is a very important cause of morbidity and, of course, significant mortality, corresponding to about 10% of mortality in patients on chemotherapy. Now, why is it significant is because when the patient has febrile neutropenia, the clinician tend to lower the dose of the actual chemotherapy so that the patient will tolerate the chemotherapy better. That is one problem. Second problem is when again the patient has neutropenia, the clinician tends to delay the chemotherapy from its actual schedule. These 2 points actually tend to compromise the treatment efficacy. Now, most standard chemotherapies commonly cause neutropenia. Now, that is a standard side effect of all chemotherapeutic agents. Usually, it occurs between, there is a 6 to 8 days of neutropenic period that is associated with chemotherapies. However, in India, febrile neutropenia is associated with about 10 to seen in about 10 to 80% of patients on chemotherapy. Now that is the statistics from India. If you take the statistics from Europe, according to the European Society of Medical Oncologists, every 8 in 1,000 patients on chemotherapy are likely to develop a febrile neutropenia episode. Now the incidence depends on the intensity of chemotherapy. Usually chemotherapeutic agents are classified based on their risk of developing febrile neutropenia as high risk, intermediate risk, and low risk. Commonly, the chemotherapies of breast cancer, ovarian cancer, and endometrial cancer has a high potential of causing febrile neutropenia. However, those agents like methotrexate that are used in palliative setting in head and neck cancers, now they are associated with very low risk of neutropenia. Now, there are some patient-related factors that has to be considered while you see a patient with febrile neutropenia. One and most significant thing is the age of the patient. Any patient on chemotherapy with more than 65 years has a high likelihood of developing neutropenia. Now, other factors are advanced nature of the disease, history of a prior episode of febrile neutropenia, poor performance status, poor nutritional status, any comorbid conditions like cardiovascular illness, poor RFT, poor LFT, or an HIV infection, bone marrow involvement of the said tumor, or a recent history of any surgeries or open wounds. All these are actually high-risk factors when it comes to febrile neutropenia. Now, prognosis is the worst in patients with a proven bacteremia. Very simply said, in patients with a proven culture report, positive culture report, the prognosis is very poor. Now, with a mortality rate of approximately 18% in gram-negative infections and 5% in gram-positive infections. Now, there is a risk assessment score called MASCC, that is Multinational Association for Supportive Care in Cancer. This risk index is what we usually use, very commonly used to risk categorize the patients with febrile neutropenia. Now, there are few characteristics that we take into account for this scoring. Mainly the burden of illness, whether the patient is having mild symptoms, moderate symptoms, or severe symptoms, presence of hypotension, presence of COPD, whether the patient is having a solid tumor or lymphoma with a prior history of fungal infection, if there is dehydration, if the patient is being treated as outpatient status, and most importantly, the age of the patient. Now, based on this characteristic, a scoring will be done. Now, maximum score a patient can have is 26. Any score which is more than or equal to 21, the patient is considered as low risk. Now, any score that is less than 21, the patient is considered as high risk. Now, high risk or low risk for what? The risk is actually set for the likelihood of developing any serious complications. The patient is low risk, meaning the patient has very low risk of developing any serious complications of febrile neutropenia. Now, serious complications meaning modes or dependence on ventilation or intubator or even death. These are the serious complications that we are talking about. Now, it will be easier if I explain the management part and the investigation part under clinical scenarios. So, I'll very briefly explain 3 clinical scenarios that we'll usually encounter in a casualty or a clinic. So, first case, it's a 48-year-old male. He's a known case of carcinoma esophagus on chemotherapy. He's on his post-chemotherapy day 12. Patient has come to you with history of fever of 1 day duration. Now, he has already done the counts. The total count is 2000 and absolute neutrophil count is 500. On examination, he is febrile, all the vitals are stable. Clinically, there is nothing. Chest is clear, per abdomen, nothing. Basically, all systems are within normal limits. Now, what we have to remember here, the most important thing is, after the patient is triage, say in casualty, after the patient comes off the triage part, the initial assessment has to be done within the first 15 minutes, ideally. Now, after that, it's always better to get a good history from the patient about the nature of chemotherapy, if he has taken any prior prophylactic antibiotics, if the patient is on any concomitant steroid use, if there is any history of any recent surgical procedures, any presence of allergies, and most importantly, any past positive microbiology, especially with an antibiotic resistant organism. Now after that, you'll do the routine clinical examination. The examination part, we'll look all the systems, but what we have to remember here is never miss the foci of infection. Now the problem with a cancer patient on chemotherapy is mostly the patient will be an elderly patient, most probably in his or her 60s. Now most will be on steroids. Now for such patients, the signs and symptoms of infection is going to be minimal. So the important part is get a good thorough examination of the patient. Don't miss the focus. Always check the oral cavity for any thrush or pharyngitis. Check the respiratory system, GI, skin for any skin lesions, oropharynx and even central nervous system so that you don't miss the meningitis. Now the investigation part that we all know, send a full blood workup with complete CBC bio including a coagulation screen and CRP or PCT. Now blood cultures, and at least send a minimum of 2 blood cultures, including one from the peripheral vein and one from any indwelling IV catheters if the patient has any. Now according to the focal signs that the patient has, send the other cultures accordingly. If any urinary symptoms, send a urine culture. If there is any cough, send a sputum culture. Get a chest X-ray done, and if necessary, get an HRCT. Then if there is any GE infection, send a stool culture. And any skin lesions, make sure that you get a swab or biopsy or even an aspirate from the skin lesion. Now, a nasopharyngeal swab may be considered if the patient has influenza-like illness. Now, coming back to a case, that was a 48-year-old with no comorbidities, no foci of infection, no dehydration, no hypotension, basically a clinically stable patient on chemotherapy with febrile neutropenia. Now this is one patient who can be managed as OPD basis. That is basically you can start the patient on a broad spectrum antibiotic and you can very well send the patient home on antibiotic. One thing that has to be remembered is it is always preferable or best if you can give the first dose of antibiotic within 1 hour of assessment. Whether oral or IV antibiotic, the first dose it is always better that you give it from the hospital itself. Now, before sending the patient home, even though it's a clinically stable patient, it's always better to consider the psychosocial and logistic conditions of the patient. The first and foremost thing, the most important thing to consider while you send the patient home is whether the patient and the family members is compliant or not. You have to make sure that they are willing to come back to the hospital if any emergency symptoms or if any worsening of symptoms happen. Not just the patient, the caregiver has to be compliant also. Now it is safe if you send the patient who is staying nearby to the hospital home so that you will be sure that they will come back to the hospital. Sending a patient who is far away home is not really a good idea because for such patients, even though an OPD management is fine, it's always better to admit him and treat the patient. The problem with febrile neutropenia is if you don't address it at the right time, you will always lose the patient. So, on how to follow up the patient, even though you are sending the patient on antibiotics home, make sure that you do a repeat count every day for the next 3 days at least. And make sure that the absolute neutrophil count is showing a rising trend. Also, tell the patient to get back to the hospital in case of any warning signs. Now, when to hospital a patient with febrile neutropenia who's being managed on OPD basis? If the patient has not had an febrile episode even after 2 to 3 days of initial empiric broad spectrum antibiotics, then always admit the patient. If the patient has initially gone into an febrile state but now he has developed repeated fever episodes again, then again it is always better to admit the patient. If the patient develops any new signs or symptoms of infection, admit the patient. If the patient cannot tolerate oral medications or if the cultures come out as a microbiology species that is not susceptible to the initial broad spectrum antibiotic that we are giving, then again it's always better to make the patient IP and manage. So to summarize, any patient on chemotherapy with no comorbidities comes to you with febrile neutropenia. Patient is clinically stable, there is no foci of infection. You can very well send the patient with broad spectrum antibiotic provided you repeat the counts for at least the next 3 days and make sure that the counts are showing a rising trend. Now, coming to the second case scenario, this is a 66-year-old lady she's a known case of carcinoma breast on chemotherapy. It is her post-chemotherapy day 12. Now, she has come to you with complaints of fever and cough. On examination, her pulse rate is elevated. It is around 106. BP is stable, 120/80. She looks dehydrated. Her WBC count is 1500 and ANC is 300. Now, if you look into this case, you can very well pick up the warning signs. She's having cough. She's having a tachycardia. She looks dehydrated. Now, this is one patient who has to be admitted. Even though she might not look really sick, she has to be admitted and started on IV antibiotics. Again, the investigation part is the same. You send all the routine CBC, bio, all the cultures, but she has to be started on a broad spectrum IV antibiotic. Here, since you can see a foci of infection, she has cough, so it's always better to send a sputum culture, get a chest X-ray done. If necessary, you can very well do a HRCT. Now, regarding the choice of IV antibiotic, that has to be decided based on local epidemiological bacterial isolate and resistance pattern. Now, it can vary with different institutions. Usually, an anti-pseudomonal cephalosporin, imipenem, meropenem, or a peptas is what we usually use as the first choice antibiotic. All these have an equal efficacy. Now, what has to be kept in mind is, for such a patient, if pyrexia continues for 72 hours while she is on IV antibiotics, then always consider an HRCT has to be considered along with a bronchoalveolar lavage. When to modify the initial empiric IV antibiotic therapy? Any patient, if the culture turns out to be positive and the initial antibiotic is showing resistance, then you have to modify the initial IV antibiotic therapy. If the patient is remaining clinically stable despite 48 hours of antibiotic therapy, then also it's always better to step up your antibiotic. Now, one extra thing that has to be done in such a patient, such a high-risk patient who is on IV antibiotic, is to give the growth factor. Now, growth factor, that is GCSF or granulocyte colony stimulating factor, is usually given so as to aid the picking up of neutrophil count. Usually, growth factors are not routinely used along with antibiotic for fever and neutropenia. However, in high-risk cases, it is always recommended to keep growth factor to improve the clinical outcome. High risk meaning if the patient has an age of more than 65 years, if the primary disease is uncontrolled, if the patient is having a prolonged and profound neutropenia, if the patient has any prior episode of febrile neutropenia, if the patient is now having multi-organ failure, or now the patient is having a clinically documented infection foci. In all these situations, it is always better to give a growth factor along with your IV antibiotic. Now, what are the advantages of growth factor? It usually shortens the duration of neutropenia, fever, antibiotic use, and subsequently it will reduce your patient's hospital stay. Now, what has to be kept in mind is the giving of growth factor will not reduce the overall mortality of the patient. The mortality will be reduced only if you start the patient on IV antibiotic at the right time. Now, what is the dosage of growth factor? Usually, the recommended dose is 5 microgram per kilogram per day subcut once a day. But what we usually give is we give a flat dose of 300 microgram subcu OD, one dose every day, and we'll keep monitoring the counts every day. We'll see the ANC. If the ANC is showing a rising trend and once it picks up above 500, we usually stop the use of growth factor. Now, along with monitoring the counts, also make sure that you monitor the vitals, monitor the fever trend of the patient. Now, how to continue treatment for such a patient? If the patient has gone afebrile and the ANC is more than 500 for at least a period of 48 hours, the patient is a low-risk patient with no foci of infection, then you can very well change the IV antibiotic to oral antibiotic. If the patient is a high-risk patient with no foci of infection on dual therapy, you may consider stopping aminoglycosides. If the culture is positive, then treat according to the specific cause. Now, despite IV antibiotics and growth factor, the patient is remaining febrile even at 48 hours. If the patient is clinically stable, you can very well continue the same antibiotic. If unstable, it is always better to step up your antibiotic. Now, if the patient has a pyrexia that is lasting for more than 4 to 6 days, always consider an empirical antifungal therapy. When to stop treatment? Once the ANC picks up, once the absolute neutrophil count is more than 500, patient is asymptomatic, febrile for at least 48 hours and the blood cultures are negative, then antibiotic may be discontinued. Now, if the ANC is less than 500, however, the patient has no complications, he is febrile, then continue the antibiotics for up to 7 days, but it has to be continued for a longer duration if the patient is a patient with hematological malignancy, or if the patient is taking a high dose chemotherapy, say in case of breast cancer, if the patient is being treated with a curative intent, she'll be usually treated with a very high dose of chemotherapy. In such patients, it's always better to continue the antibiotic up to 10 days. Now coming to so basically the second case was a young patient with fever, febrile neutropenia, with the foci of infection. It's always, and who is not clinically stable, it's always better to admit and start on IV antibiotic along with growth factor with daily monitoring of counts. Now coming to the last case scenario. So this is a 54-year-old gentleman. He is a known case of carcinoma rectum. He's on adjuvant chemotherapy, meaning he has already completed the surgery part and now he's taking chemotherapy after that with something called FOLFOX regimen. He has presented to you with fever of 2 days duration. Now his absolute neutrophil count is 112. Now this patient, he looks sick, he has tachycardia, he has hypotension, he looks dehydrated, and when you look at the patient, there is erythema around the central line insertion. Now, catheter-related infections is one common thing that we usually see in patients on chemotherapy. Now, there is something called differential time to positivity that you look for in catheter-related infections. It means the difference in time interval between the blood culture that is drawn from the catheter hub and the peripheral vein. That is basically, if you suspect a catheter-related infection, you'll always get a blood culture from the peripheral vein and the catheter. Now, if the time interval between the positivity of the blood cultures is more than about 120 minutes, then it is said that catheter is likely the source of infection. Now, why this thing called DTP is important? This technique is important because it helps to diagnose whether the catheter is actually the source of infection, so that an unnecessary removal of catheter can be prevented. It is especially beneficial in patients on long-term catheters. In chemo patients, getting a vein and putting in a catheter is very difficult. So in such patients, an unnecessary removal of catheter may be prevented. So, but whatsoever, any catheter retention is always said to be associated with an increased risk of infection. Now, what are the indications of line removal? Any tunnel infections, pocket infections, any persistent bacteremia despite antibiotics, any atypical mycobacterial infections or candidemia, all these are actually indications for removal of the line. So in these patients, vancomycin or teicoplanin will be an ideal first choice antibiotic for treatment. Now, the rest of the part will be the same. These patients has to be given a growth factor along with IV antibiotic. Count has to be monitored every day. Once the count picks up and patient becomes stable, growth factor can be discontinued and subsequently antibiotics can be tapered also. Now, there is something called primary prophylaxis that we give because most patients on chemotherapy are at a very high risk of developing febrile neutropenia. So what is usually done is, along with chemotherapy itself, after 24 to 72 hours of chemotherapy, a prophylactic dose of growth factor will be given to patients who are on very strong chemotherapies. Now this can reduce the risk of febrile neutropenia by about 50%, subsequently reducing the chance of hospitalization and infection. Now, most important thing is this will enable the delivery of full dose of chemotherapy according to the schedule. Now, growth factors usually give minor side effect of bone pain, which can be very well managed with NSAIDs. Now, to summarize, why this topic is important, despite major advances in prevention and treatment of febrile neutropenia in patients on chemotherapy, it still remains the most frequent and most serious complication that is associated with cancer chemotherapy. Now, it is the most important cause of morbidity, use of healthcare resource, and compromised treatment efficacy that is resulting from delays and dose reductions in chemotherapy. Now, we do have a risk assessment index that we usually follow in order to risk stratify the patient as low risk and high risk. High risk patients has to be handled with utmost care. Now, elderly patients, now when you see a patient, when a patient on chemotherapy comes to you with febrile neutropenia, make sure that you do not miss any foci of infection. So make sure that you always examine the patient thoroughly. Now, elderly patients, especially on steroids, might not have any frank symptoms or signs. Always the signs and symptoms are going to be minimal in a patient on chemotherapy. Now, it's always better to give the first dose of antibiotic therapy, whether oral or IV, within 1 hour of your assessment. It do have a significant effect on morbidity. Now, young patients with no foci of infection, no dehydration, if clinically stable, can be very well managed as OPD basis. He can be sent home with a broad spectrum antibiotic, provided you have to monitor the counts at least for the next 3 days. Now, a high-risk patient with a frank foci of infection or a patient who is clinically unstable, manage the patient as IP with the support of growth factor. That's all. Thank you.
Thank you, Dr. Parvati, it is an excellent presentation on a very important topic. And I am extremely happy that your presentation was so clear and you are so confident. And it is just because you are thorough with the topic, then only you can be so confident in presenting this topic in an easy way. And I am not a clinician, so I don't know how much the clinicians benefited from this. But I am sure that our students might have got enough and more information on the topic. And if they had followed clearly, they'll get one or the other question in the forthcoming examinations, because majority of the questions now are clinically oriented. And one or the other point you heard from this presentation you can use in your clinical questions at one time or the other. I don't know how much you had benefited or how much you had concentrated on the topic. And if any, because I am not a clinician, I have no questions, but the clinicians can, if they want to ask questions, 1 or 2 questions, I shall. The students also can ask questions. എന്തെങ്കിലും കേട്ടെങ്കിൽ എനിക്ക് അറിഞ്ഞൂടെ എത്രമാത്രം കേട്ടെന്ന്.
Excellent presentation, Ms. Parvati. I got to have a doubt. The thing is that febrile neutropenia is it more common in a particular organ? Because carcinoma is almost there in almost all organs.
Yes, sir. But usually it is associated with the chemotherapy that we are giving. So for an allied specialty, especially for a physician, you have to keep in mind that most of our females are going to have either breast cancer or ovarian cancer or endometrial cancer. These 3 cancer chemotherapies are most likely to present with neutropenia. So if you can keep that in mind, you'll never miss that. Not exactly the organ part, but it is mostly associated with certain chemotherapy regimens, especially these 3 cancers.
Thank you.
Thank you, ma'am, for this enlightening talk. Myself, Dr. Azad, I'm first year PG resident. I had a doubt. It was mentioned that GCSF can be given as prophylactic in high-risk patients for neutropenia. So is the same applicable in case of hematological malignancy? For example, if a patient is an AML patient, post-intensive chemotherapy, he is going into neutropenia. If we give GCSF therapy, won't it increase the AML blast cells also?
No, usually the hematology is a totally different aspect of it. You're messing with the blood cells there. Usually we give it as a prophylaxis only for solid tumors. There, after the intensive chemotherapy part, the patient goes to a neutropenic phase because of the disease part also. It's not just the chemotherapy part. So usually we don't give that in hematological malignancies. We give it as prophylaxis only in solid tumors, especially those solid tumors who require intensive chemotherapy. Intensive meaning higher dose or those chemotherapies that are given as weekly or maybe 2 weekly schedules. We usually give that for solid tumors alone, not for hematological tumors.
So for lymphomas also it's applicable?
Lymphomas, yes, sometimes. Not for all regimens. Maybe for R-CHOP and all, we do give GCSF. For others, we don't really.
Thank you.
Ma'am, any role for oral antibiotic initiating early itself?
Yes, sir.
What is your choice and of oral antibiotic?
We usually give Augmentin or Ciplox. That is what we usually, for some patients, they do actually benefit. Along with this, just like Dr. Asad asked, along with prophylactic GCSF, we also give prophylactic antibiotic. We ask them to take immediately after chemotherapy for the next 5 days. They do benefit.
For infection marker, what is the marker you are depending? Because CRP will be elevated, even specific like procalcitonin or anything like that, or can be associated with viral infection also.
We do usually do the PCT, sir, not CRP. We usually depend on PCT. Yes. Now again, I am no one to teach a physician on how to manage an infection. The physicians will be better in that aspect. No, sir.
Any risk index, like any scores, like
No,
how we have
only
for cardiovascular ASCVD risk? So is there something like that for febrile neutropenia?
No, sir. No risk index to categorize the patient immediately after chemotherapy. We do have a risk index, but only once the patient presents with febrile neutropenia to evaluate if he has a risk of going into serious complications. We cannot evaluate it beforehand.
Okay, I've heard of a risk index score called as MASSC. So
That is, we use when the patient presents with febrile neutropenia. Once they present to us, we'll do the risk scoring. There is something called, its maximum score of 21. Any score more than 20, its maximum score is 26. Any score more than 21, the patient is at low risk for developing serious complications of febrile neutropenia. Anything less than 21, the patient is actually at higher risk of developing complications of neutropenia.
Is it different for hematological and solid organ?
Usually taken for solid tumors.
Solid tumors. Thank you.
Thanks.
Dr. Parvati, what antifungal will you start, oral or IV?
What?
Persistent fever. When the fever persists despite the antibiotics,
Okay.
you
What?
said to add antifungal.
Usually fluconazole only, sir.
Orally?
Yes.
And for how long do you continue?
Usually at minimum of 10 days.
10 days, thank you.
Thank you so much. I think there is no more questions now. If at all any questions, you can have it or you can discuss it during lunch time. Thank you, Parvati, for the nice and excellent presentation. I am extremely happy to see you also. Thank you. Thank you so much.
Thank you.
Now I invite Dr. Shashikala ma'am to hand over the memento and certificate to the speaker, Dr. Parvati ma'am. We now invite Dr. Rajashekharan sir, Head Department of Medicine, AZEEZIA Medical College, to present a gift to Dr. Shashikala ma'am.
Members of the house-ന് സാധാരണ ഗിഫ്റ്റ് കൊടുക്കാറില്ല. We are one family.
Now we move on to the next session. Breathing so effortless, so automatic, until the moment it isn't. In critical junctures where the lungs falter and life hangs in the balance, mechanical ventilation steps in as a silent lifesaver. Today's session, the basics of mechanical ventilation, brings us back to the foundation of critical care, a life-supporting intervention that every clinician must not only understand but master. From understanding modes and settings to recognizing patient-ventilator synchrony, this session promises to demystify the mechanics and instill clarity in complexity. The session will be chaired by Dr. C. Shashidharan Sir, Consultant Physician, AZEEZIA Medical College, and Dr. Amal P. Sir, Consultant Family Physician, Mada Medical Center, Kollam. We are privileged to have with us Dr. Unnikrishnan Sir, Head, Department of Critical Care Medicine, Travancore Medical College, Kollam. I now invite Dr. Unnikrishnan Sir to the stage.
Dear friends, my duty is to formally introduce the speaker to you. Dr. Unnikrishnan, MBBS, DNB, FNB, IF, CCM, is now working as a head of Department of Critical Medicine, Travancore Medical College for the last 3 years. Academically, he was the national topper in the Indian Federation of Critical Care Medicine exam in 2022, and he is a AHA certified instructor for BLS as well as ASLS courses. Before coming to Travancore Medical College, he has worked in KIMS Health, Trivandrum. His special areas of interest are advanced mechanical ventilation, hemodynamic monitoring, and ECMO services. With this introduction, I would like to request Dr. Unnikrishnan to go with the presentation.
Thank you, sir, for the nice words. At the outset, let me thank the Department of Internal Medicine at AZEEZIA Medical College for having me here. I am really privileged to be a part of this event. So, my topic is mechanical ventilation, basics of mechanical ventilation. So, my target audience is all those who are sitting at the back. So, I want all of you to pay some attention. So, how many of you have seen a patient in the ICU on the ventilator? Can I have a show of hands? The junior doctors. How many of you have seen? Okay, maybe 50-50. So, here I am going to discuss a patient with COPD admitted under general medicine in ward, suddenly developed a breathing difficulty. He is shifted to ICU. He has been intubated and is on the ventilator. So, what all you should know as basics, I am not going into advanced, for managing a patient on the ventilator. Let us see. So, I would be dwelling into some of the physics behind ventilation. What are the basic concepts? And you should be also aware of the complications that could develop because of the patient being on a ventilator. So, this is a basic equation. So any patient getting ventilated, you should be aware of this equation. So you are having a patient with endotracheal tube. Endotracheal patient is intubated and is connected to a ventilator. So from ventilator to the patient, you have two parts, the endotracheal tube as well as the lungs. So the part of the endotracheal tube is accounted for by the flow and resistance. The amount of air flow you are giving and the resistance offered by the tube. So for example, if it is a COPD patient with severe bronchospasm, how will the resistance be? It will be low or high. COPD patient, it's an obstructive airway disease. So the airway resistance has to be high. So you should aim for reducing the resistance. What are the mechanisms? How can you reduce the resistance? Medically, anyways, you will be giving proper medications like nebulizations, bronchodilators, corticosteroids. On ventilator also, we should do some adjustments. I'll be discussing on it. So this flow into resistance is up to the level of endotracheal tube. Then comes the volume divided by compliance. That is, this long line you could, this is the endotracheal tube and this round is the lung. Okay. So tidal volume, the tidal volume is the amount of air normally going in and out of the lungs during quiet breathing. The tidal volume divided by lung compliance, that is at the alveolar pressure. So this is the air flow into resistance accounts for the airway related pressure and volume by compliance for the alveolar pressure. So the inflation pressure in the lung, this formula is very important. Flow into resistance plus volume divided by compliance. Plus you need to add one more thing, which is a baseline pressure, which is PEEP, positive end expiratory pressure. Am I clear? So any patient on the ventilator, these are the parameters that works on the patient. So again, alveolar pressure is volume divided by compliance plus PEEP. So what are the parameters that are fixed? You need to set some settings on the ventilator. Or in these, what are the settings that you give? Flow is one you set. You can't change it. It's a set parameter. And tidal volume also you set. How will you set the tidal volume? How will you set tidal volume on the ventilator? Usually 6 ml per kg predicted body weight. If the predicted body weight of the patient is 50 kg, how much tidal volume will you set? 50 into 6, which is 300 ml. So again, tidal volume is a set parameter. Tidal volume, flow is also set. PEEP also you will be setting. So what are the parameters that you could influence? The resistance within the airways, I already mentioned, the resistance of the airways as well as lung compliance. So 90% of the patients on the ventilator in the ICU are usually either COPD patients or patients with pneumonia, ARDS and also. All those are patients having resistance related problems and compliance related problems. So we need to tailor that therapy accordingly. So again, flow into resistance. Flow is obtained by ratio between volume and time. Volume divided by time. Again, time is a set parameter. Volume also you are setting. So in any patient you can set only one of the three, either flow, volume or pressure. If you set the flow, according to that flow, the tidal volume and airway pressure changes, same vice versa applies. So what is the purpose of ventilating a patient? Why you are putting the patient on a ventilator? To do the function of lungs. What is the function of lung? To take in oxygen and remove carbon dioxide. So you should be aware of this. So to give in oxygen and remove carbon dioxide. So what are so we need to determine the parameters that drive in oxygen. What is the first parameter? What is the fraction of oxygen in the air we are breathing right now? 21%. So very good. You should be aware of the FiO2. In a ventilator, the FiO2 is the fraction of oxygen. Inspired oxygen ranges from 21 to 100%. And when you receive the patient for the first time, how much FiO2 you will set? 100%. Then based on the ABG oxygenation value, so you come down on the oxygen. Okay, so that is FiO2. That is one parameter that influences oxygenation. Then mean alveolar pressure. Mean alveolar, that is a pressure at the mid level of the airways. That against, if that pressure is low, again your oxygen level will be low. First is FiO2. If a patient has a saturation of 80%, you are keeping 21%, you are not giving enough oxygen to the patient. So that will help produce desaturation. So you have to give high oxygen. Again, you have to increase mean alveolar pressure. Third is PEEP. What is PEEP? Positive end expiratory pressure. That is the pressure that is left in the lungs after a normal expiration. You are not allowing the lung to completely collapse after complete an expiration. You are breathing out. Your lungs are collapsing, but you are not allowing the lung to fully collapse. So it is easy to open the lung in the next inspiration. So that is PEEP. Usually we set PEEP at around 5. That helps in easy reopening of the alveoli, especially in diseased states. So these are the main parameters that influence oxygenation in your patient. So what are the factors that drive out carbon dioxide? First is ventilation. What is minute ventilation? Minute ventilation is a product of respiratory rate into tidal volume. For example, your tidal volume is 500 ml. Take it as 0.5 liters. 0.5 liters into respiratory rate is 10. 0.5 into 10, which is 5 liters per minute. That is a minute ventilation. So usually the ventilation has to be around 6 to 8 liters per minute. All these will be displayed on your ventilator parameter button. So again, what are the factors that influence mean airway pressure? Again, we need to titrate the oxygen according to the FiO2 according to the saturation. Again, mean alveolar pressure also determines the oxygen level. So you can increase the tidal volume by adjusting the mean airway pressure. See, you increase the tidal volume, the mean airway pressure also increases. You could see. Means for a patient with for an adult male, how much is the tidal volume required? I already told, for a 60 kg person, 60 into 6, 360 ml. If you have set the tidal volume at 200 for a 360 required patient, there will be desaturation. So when you increase the tidal volume to 360, there will be an increase in mean alveolar pressure. So the other way to increase the mean alveolar pressure is to increase the inspiratory time. What is a normal IE ratio? What is IE ratio? Inspiratory expiratory ratio in a normal person. The normal way we breathe. What is a normal IE ratio? It is 1:2. 1:2. That also we can set on the ventilator. 1:2 is a usual rate we set, and depending upon the pathology, if it is a COPD patient, we need to prolong the what phase? Expiratory phase. So you can change the IE ratio to 1:3, up to 1:5 you can do. If you want to improve the oxygenation, you have to increase inspiration at the cost of expiration. So you can come down on IE ratio to 1:1.5, 1:1.1. So by increasing the inspiratory part also, you can improve the oxygenation and mean alveolar pressure. So how to set the IE ratio? We know which phase of respiration is the active phase. Only inspiration is active. You set the inspiratory part and expiration, automatically the expiratory part is adjusted accordingly. So expiratory time is not set, and the remaining time after inspiration before the next breath is the expiration. So again, flow rates also influence the inspiratory time. Again, you can increasing the inspiratory time improves the oxygenation. Dysynchrony can occur. What is dysynchrony? Dysynchrony or asynchrony? You are putting the patient on the ventilator. Will the patient tolerate the tube? Patient is trying to breathe by himself, the ventilator is also giving a breath. So the patient is fighting with the ventilator. So that is called dysynchrony or asynchrony. Ventilator is delivering a breath, patient is also trying to breathe. Both are not synchronous. So that will lead to dysynchrony. So that can be prevented by giving sedatives. So inspiratory time increase can also lead to gas trapping because you are reducing the expiratory time. Expiratory time is the phase for which the gases come out. So when you increase the inspiratory time, gases will not come out completely. So that leads to gas trapping, which will be deleterious in obstructive airway disease. So again, mean airway pressure can also be increased by increasing the positive end expiratory pressure. PEEP helps in improving oxygenation by increasing mean airway pressure and reduces the shunt fraction. So what are the, just an idea as to what are the parameters we set on the ventilator. You have the patient on ventilator, what are the parameters you set? First is FiO2. I already said FiO2 button, you can titrate from 21 to 100% you have. Then you have the PEEP button. So FiO2 and PEEP are the main parameters, buttons you should work on to improve the oxygenation. FiO2 and PEEP, and not, then you have two more buttons, which is respiratory rate and tidal volume. FiO2, PEEP, respiratory rate and tidal volume. First two for oxygenation and the remaining two for ventilation. The primary purpose of ventilation is give in oxygen and remove carbon dioxide. First two, FiO2 and PEEP, for improving the oxygen levels, and the remaining two, respiratory rate and tidal volume, for washing out the carbon dioxide. So what are the complications just because a patient is on ventilator? Are you ventilating the patient adequately? What is the most common ABG abnormality you see in a patient in ICU? The most common ABG abnormality you see in the ICU is respiratory alkalosis, which is iatrogenic, just because you don't know to set the ventilator. In any ICU, respiratory alkalosis is the most common. You are hyperventilating the patient. Respiratory alkalosis. So nosocomial infections. You have to ventilated patient, if possible, you should give 1:1 staff nursing, regular ET suctioning. Once you should not, once ventilated, you should not regularly open the disconnect the ventilator to do suctioning and all. You should put devices like closed suction devices and all. Okay. First is nosocomial infection. Next is ventilator associated lung injury. What do you mean by ventilator valley? What is valley? Ventilator associated lung injury. If you are ventilating at high pressures you are giving, it will cause rupture of the alveoli, leading to pneumothorax, pneumomediastinum and all. That is called barotrauma. Then if you are giving too much volume, suppose a patient's tidal volume required is only 360 ml, you have kept the tidal volume at 500 ml. That will cause increased tidal volume, which will cause volutrauma. Then shear injury, because of you increase the respiratory rate, repeated opening and closing up of the alveoli will cause shear injury. That is called atelic trauma. Again, if you are keeping inspiratory phase high, that will lead to gas trapping, leading to reduced exhalation, leading to increased carbon dioxide and all. Then predisposing factors for which could aid gas trapping are obstructive airway diseases and bronchial asthma. Which the causes are you are increasing the inspiratory time, high tidal volumes and high respiratory rates. This is what the effect of gas trapping, which is due to hyperinflation, and that is intrinsic PEEP. What is intrinsic PEEP? What is intrinsic PEEP? I think are you all able to follow me? What is intrinsic PEEP? I already told you that you set a button called PEEP button. It is usually around 5, up to 8 you can set. But in obstructive airway disease, what is happening in a COPD patient or an asthma? Why is he gasping for breath? And he has a hyperinflated barrel chest. Because of obstruction, it is obstruction to expiration. During expiration, breath is not completely exhaled. So before completion of expiration, he is taking in another breath. So already there is gas trapping. All that leads to the development of a PEEP. Added to that PEEP, you are keeping, means that PEEP is already there in the lung. That is called intrinsic PEEP. Intrinsic PEEP. And it is a PEEP that you set on the ventilator, that is called extrinsic PEEP. PEEP I is intrinsic and PEEP E is extrinsic. So this PEEP E you are setting on the ventilator. This PEEP I, how will you calculate? You can calculate. If your patient on ventilator, there is a button called end expiratory hold. At the end, if you press that button, you could see the total, this is the PEEP that you set This is a total PEEP, and subtract the total PEEP from extrinsic PEEP so that you will get the intrinsic PEEP. Why do you want to know the intrinsic PEEP? Suppose the intrinsic PEEP is 5 or 10 or 15. It is very much damaging to the patient. It could cause a cardiac arrest because intrathoracic pressure is very high, so venous return and all will decrease, so hypotension will develop. That could worsen the patient. So you can, so to wash out this PEEP, what will you do? What is the treatment that you can offer? Suppose I am telling you, I have set the PEEP at 5 externally and intrinsic PEEP is 10. What will you do? You need to wash out the carbon dioxide. For that, you can increase the expiratory time, prolong the expiratory phase. You can increase the IE ratio from 1:2 to 1:4 maybe. And you reduce the respiratory rate. Usually your reflex, when you see a type 2 failure, carbon dioxide of 60, 70, automatically our hand goes to the respiratory rate button. Rate increase cheyu. നമ്മൾ ഫോണിൽ കൂടെ ഒക്കെ പറയും respiratory rate 16 വെച്ചിരിക്കുന്ന 24 വയ്ക്കൂ. Actually you are doing more harm to the patient. The primary therapy change IE ratio change to 1:4 or 1:5 and reduce the respiratory rate. That is a therapy for that. So all this I mentioned. So what are the cardiovascular effects of gas trapping? What are the cardiovascular effects? Because of gas trapping, already the intrathoracic pressure rises. Your intrathoracic pressure rises means what? Your venous return to the heart is, there is high pressure within the thorax. So venous return to the heart reduces. So your venous return is your preload. The preload to your heart reduces. Then what? Because your preload reduces, that will exacerbate the, that is exacerbated by the increased inspiratory pressure and increased inspiratory time, increased PEEP. And it will also reduce the transmural pressure or the afterload. So because of the patient being on ventilator, your preload and afterload are reduced. So you should be aware of that. So when you put a patient on ventilator, you could see that the patient could develop a hypotension. So you should be very well aware that when you intubate a hypovolemic patient or a trauma patient, immediately the patient would be having a BP of 120/80. Immediately after your intubation, you will be giving sedatives also. The influence of sedatives will also come into play. After the intubation, the patient will land upon a noradrenaline high dose. So you should fill these patients with fluids prior to intubation. So any normal intubation will reduce the preload and afterload. But this is beneficial in one category of patients. Which category of patients? Mechanical ventilation. Patients with heart failure and pulmonary edema. See, we know the treatment of pulmonary edema is reduce the preload, reduce the afterload. You are reducing the preload by, we are giving Lasix, we are giving NTG. So these are the positive pressure mechanical ventilation is beneficial in those with heart failure. But be wary in those patients, traumatic patients, hypovolemic patients, when you intubate, that can exacerbate the hypotension. So all this will lead to LV dysfunction, which will increase the cardiac output. And for a normal LV function, that will lead to reduced cardiac output. So hypotension, in this case, consider drugs. We will be using propofol, opioids and all for intubation. So, and you are reducing, already patient has a sympathetic drive. You are blunting the sympathetic drive with the sedative. So that will lead to hypotension. Again, gas trapping, barotrauma, volutrauma. And because of high pressures you ventilate, what will happen? Barotrauma will lead to pneumothorax. You should be regularly examine the lung, chest of the patients for development of a pneumothorax. So lastly, to summarize, this formula, the airway pressure at which we are ventilating, can you say with me? Flow into, please say with me. Flow into resistance plus volume divided by compliance plus PEEP, where the except resistance and compliance, all others are set parameters. Resistance and compliance as a parameters we need to alter with the ventilator. Then the PO2. PO2 is determined by the PO2 means the oxygen at the alveolar arterial level. That is influenced by the FiO2 you set and the mean alveolar pressure. And then the mean alveolar pressure, again PEEP and IE ratio. Next is PaCO2 is influenced by the minute ventilation, which is respiratory rate and product of respiratory rate and tidal volume. So, and lastly again complications. With this, I conclude my presentation. I can understand that basics of ventilation it's very difficult to
Thank you, Dr. Unnikrishnan. It was a well explained session. Any questions from audience?
My suggestion to the juniors is we should be very well aware of the respiratory physiology part. Respiratory physiology, what is airway, what is trans airway pressure, trans respiratory pressure, trans pulmonary pressure, what is lung compliance, what is chest wall compliance. All these should be in and out. We should know. Then only we will be able to go into details of all these, what is PEEP. So that is my only request to the juniors. Go and get familiarized about the various lung physiology parameters.
Thank you, Dr.
Thank you, Dr. Unnikrishnan sir, for the wonderful session. Now, I invite the chairs to hand over the memento and certificate to the speaker, Dr. Unnikrishnan sir. Thank you, sir. We now invite Dr. Abdul Majid sir, Consultant Physician, Karunagapalli, to hand over a token of appreciation to Dr. Shashidharan sir. Thank you, sir. We now call upon Dr. Anil Vijayakumar sir, Professor, Department of General Medicine, AZEEZIA Medical College, to present a gift to Dr. Amal sir. Thank you, sir.
We now move on to session 5 of our CME, Insulin Inside Out, Strategies for a Seamless Glycemic Ride in Clinical Practice. In the ever-evolving landscape of diabetes management, insulin remains a cornerstone therapy. Yet, despite its long-standing role, optimizing insulin use continues to pose clinical challenges, from initiation and titration to patient acceptance and adherence. A seamless glycemic ride requires not just science, but strategy, tailored to each patient and practice setting. Chairing this session, we have Dr. K. Srikanthan sir, Professor, Department of General Medicine, AZEEZIA Medical College, Kollam, and Dr. Hari sir, Associate Professor, Department of Biochemistry, AZEEZIA Medical College, Kollam. To guide us through these critical strategies with clarity and confidence, we are proud to present our very own physician, Dr. Amit sir, Associate Professor, AZEEZIA Medical College, Kollam. I invite Dr. Amit sir to the stage.
subject of presentation is use of insulin. I think insulin has been used for the last 100 years after the and now initial insulin was impure insulin, maybe present from animals. Now we can recombinant insulin is there, regular insulin is there, short acting insulin is there, rapid acting insulin is there, intermediate acting is a mixture insulins are there, and we should know the pharmacodynamics and pharmacokinetics for proper use of insulin. Dr. Amit will deliver the subject in a prompt way.
Good morning, one and all. So today my topic is insulin inside out. So, and strategies for a seamless glycemic ride. So before going to the topic per se, we must be knowing why we should be knowing insulin, especially practicing in India. So the burden of diabetes is in India. As of now, there is around 10 crore people suffering from diabetes in India. And if you look at the average HbA1c of diabetes patients, it is 2% higher than the recommended value of 7%. That means most of the patients in India suffering from diabetes are uncontrolled. So 10 crore people suffering from diabetes and most of them are uncontrolled. Okay. So looking at the Asian Indian phenotype, we even though appear thin, our body, we have a normal BMI, the visceral fat in the present around the visceral organs in the abdomen will act as an endocrine organ and will release lot of inflammatory markers leading to increased insulin resistance. This increased insulin resistance will lead to hyperglycemia, and this hyperglycemia lead to glucotoxicity of the beta cells of pancreas, further worsening the blood sugars and leading to lot of complications of diabetes. Along with that, adding to that, what happens, we South Indians take a high carbohydrate meal. So normally, compared to Caucasians, for a same carbohydrate load, the same carbohydrate meal, Indians, South Indians or South Asians will have a 2 to 3 times higher blood glucose rise for the same carbohydrate load compared to Caucasians. So what are the evidence from the Indian studies? If you look at the evidence, the average HbA1c level of Indian studies shows that it is around 9%. Most of them are on the range of uncontrolled diabetes. So what's the problem with uncontrolled diabetes? 1 year of uncontrolled diabetes can lead to the development of microvascular complications, especially nephropathy and neuropathy in the range of around 20%. Just imagine 1 year of uncontrolled diabetes, and also the amount of macrovascular complications to the range of around 60%, especially myocardial infarction and heart failure. So 1 year of uncontrolled diabetes, there will be 70% chance of the patient developing a cardiac failure or a myocardial infarction. So what we mean by achieving the target? So what's the target set by the different guideline organizations? The target set by ADA and RSDA is the fasting the HbA1c target for young people without much comorbidities is less than or equal to 7%. But for people who are having older people or people with multiple comorbidities, they have given a relaxed cutoff of around 7.5 to 8%. So compared, and the fasting glucose cutoff is around 80 to 126 or 130 milligram per deciliter, and the postprandial glucose cutoff is around 180 milligram per deciliter. So this by achieving target, we want to achieve, this is the target, HbA1c of less than or equal to 7, and fasting glucose of less than 130, and postprandial glucose, 1 hour postprandial glucose of 140, and 2 hour postprandial glucose of 180. So what's the advantage of achieving euglycemia? That is HbA1c less than 7. We already discussed we can prevent the development of macro and microvascular complications. Not only that, we can also, the different studies have shown that by achieving euglycemia per year, the diabetic related treatment cost can be reduced by 25%. So imagine, but 1 year of controlled diabetes, the diabetic related cost can be reduced by 25%. And coming to the Indian scenario, we already discussed that most of the Indian patients, 93% of the Indian patients who are diagnosed with diabetes are already on treatment. They are taking some 1 or 2 oral antihypoglycemic drugs or even insulin. But see, if you look at that, 93% of the patients, so only the 35% of the patients are on insulin, even though 80% of the patients who are diabetes in India is an uncontrolled range. Only 35% of them are taking insulin. So why? We know that insulin is the best drug to control hypoglycemia. Is that with insulin we achieve the maximum control of blood sugars and HbA1c. But still, lot of people are uncontrolled. We are only giving insulin only for 35% of the people. Why is that? There are patient-related barriers and there are physician-related barriers. So what are the patient-related barriers? Patient has a fear of hypoglycemia, fear of weight gain, then personal failure. They have the fear of cost. Then lot of myths around, misconceptions around, and the psychological factors where the patient thinks that what others will think if then they see that they are taking insulin, and the change in lifestyle, they have to carry it wherever they go. So those are the patient-related barriers. Then there is physician-related barriers like compassion fatigue. We have to spend more time explaining to the patient the need for insulin, the advantages of insulin, that we don't have to spend a lot of time with the patients. Then fear of doctor shopping. When we advise the patient to take insulin, the patient may go to another doctor who will prescribe them with OHS. Then adverse effect of insulin. We want to sometimes treat the adverse effect. Then another thing here, it is a burdensome regimens. The regimens by which we have to start the patient on insulin. So now we will move to what are the definite indications where we should start the patient on insulin. The definite indications. Obviously, the first one is type 1 diabetes, we all know. Second is pregnancy. Pregnancy, you can start the patient on metformin, but the next drug should be insulin. Then there perioperatively or patients in acute illness, sepsis, better to start the patient on insulin. Then diabetic ketoacidosis, we know insulin is a drug of choice for diabetic ketoacidosis. Then CLD, CKD. CKD, we have better options now with SGLT2 inhibitors until the GFR is up to 20. If it's less than 20, we can only take the insulin. We can only start on insulin. Then OHA failure in type 2 diabetes. What is OHA failure in type 2 diabetes? When these patients taking OHS, especially secretologues like glimepiride, when they are taking it for a long time, after a few years, these glimepiride, what they do is, the secretologues, what they do is, they squeeze the pancreas to release more and more insulin. So after squeezing it for some time, what happens is the insulin level of the pancreas, insulin storage of the pancreas reduces, and there won't be any more insulin available in the pancreas to secrete it. That's called as secondary OHA failure. So these are the definitive indications of insulin. So now in case of, we'll move to type 2 diabetes patients. When already patients who are on type 2 diabetes are taking multiple oral anti-hypoglycemic drugs, when we should really start the patient on insulin. What the guideline says. According to Indian guidelines given by RSSDI, we should start the patient on insulin when the patient fails to achieve the glycemic target with the 3 oral anti-hypoglycemic agents. So after adding 3 agents, still the patient's optimal dose of 3 agents, still the patient's blood sugars are uncontrolled, you should start the patient on, instead of the 4th agent, before adding, the 4th agent should be a insulin. Also in patients with a severe symptomatic hyperglycemia, when patients have symptoms of severe hypoglycemia, or patients where they are in having symptoms like weight loss, okay, in such patients, metabolic complications of diabetes, in such patients, better to start the patient on insulin. So why they made the cutoff of only 3 oral drugs should be given? So where patient is already taking single drug for a diabetic patient taking single OHA, when they comes and if the sugars is uncontrolled, if you add a second agent, the HbA1c reduction we can achieve is only 1%. If you add a third agent, the HbA1c reduction achieved is around 0.5%. But if you see, if you add a 4th agent, instead of the HbA1c reducing, it increases by 0.2%. So that's the difference. So when up to 3 agents there is a reduction in HbA1c, but when the 4th agent is added, there is not significant reduction in HbA1c. So there is no point in adding an oral agent as the 4th agent. It's better to go with insulin. So what is the ADA guideline says? ADA also says after 3 agents, if the patient's HbA1c is not achieved to target, you should start the patient on insulin. And only variation is in patients who are having obesity or patients who are having, patients with obesity, patients with atherosclerotic cardiovascular disease. In such patients, we can, if you are trying for an injectable, before giving insulin, we can give 1 dose of, before giving insulin, we can start on GLP-1 receptor agonist or GIP-GLP combination, which is available in India with a higher cost. Because these agents can provide weight loss can improve can reduce the atherosclerotic cardiovascular risk. So AD has given that before adding insulin, in the injectable you can give GLP-1 RA. But if the patient doesn't have a atherosclerotic cardiovascular risk, or if the patient is having doesn't have obesity, a patient your sole aim is to achieve glycemic control and prevent complication. In such patients, insulin is a best agent. So what is insulin? You know, basically it's a polypeptide hormone secreted exclusively by the beta cells of pancreas. And before going to the strategies for implementation of insulin, we should know what's the basic way which the insulin is secreted in our body, how the pancreas secretes insulin. Because mimicking the physiological secretion is the best way to control hyperglycemia. So insulin is secreted in pancreas in a continuous manner and in a phasic manner. 50% of the insulin is secreted by the pancreas in a continuous low dose manner throughout the day for 24 hours. That insulin, we take it as basal insulin. The aim of that insulin is to prevent fasting hyperglycemia. Because during fasting state, in the absence of insulin, our body will start lipolysis and gluconeogenesis. This is one that favors the fasting hyperglycemia. That is fasting sugar. So basal insulin is, this concept is very important. Basal insulin is the one that checks the fasting hyperglycemia. Then according to the food we eat, the carbohydrate load we take, the pancreas will secrete a bolus of insulin to tide over the carbohydrate load before each meal or with each meal. So that insulin secretion is called as the bolus secretion of insulin. So usually in normal patients, it's a 50% is the basal insulin secretion and 50% is the bolus insulin secretion. So this is the phasic manner of insulin secretion. So with each meal, there is a rise as the blood sugar glucose rises. This is the bolus secretion of insulin. And throughout the day, even at night time during the fasting state, the pancreas will release a low dose of insulin until unless we are going into hypoglycemia. That is the basal secretion. This is the bolus secretion. Okay, with each meal is the bolus secretion. So what happens in diabetes? Diabetes, this response is blunted and delayed. So I'll just skip slides. So when they identified the need for insulin from external sources, what they have done now they are doing is they are implemented that recombinant DNA technology. They are replaced our genes that are responsible for insulin secretion in the yeast and making the yeast secrete insulin, and they are collecting it in bottle. So such insulin we get is the regular insulin that we get. Commonly the brand name is Atrapid we use, or insulin R, or human insulin. This is the regular insulin. It is a clear transparent insulin. So this is the regular insulin, and it has the same pharmacokinetic properties like the insulin secreted in our body, because the same genes are responsible for secretion of this insulin. So it's the same pharmacokinetic properties for this insulin compared to with the insulin secreted in our body. So what we try to, this was the first insulin invented, so we try to, what happens if we try to manage hyperglycemia with this insulin? Let us see. So this insulin has a pharmacoproperty. Once you inject it, it will increase, start acting within 20 minutes, and peak action will be around 4 hours, and the action stops by 6 hours. So this is a short-acting insulin. So insulin, a regular insulin is a short-acting insulin, and if you give, you can use it as a bolus insulin. So if you give it before each meal for a bolus secretion of insulin, what happens is the insulin is given, and 20 minutes after when we eat food, there will be the blood sugars will start rising immediately, and the blood sugar will reach the peak within 1 or 2 hours. But the insulin will take 4 hours to peak. So immediately after the eating, there will be since the blood sugar peaks at around 2 hours, there will be hyperglycemia, and the insulin peaks at around 4 hours, so there is a chance of delayed hyperglycemia. That's why when we treat the patients with Atrapid 3 times a day, there's a chance of these patients developing hypoglycemia around 11 o'clock. So immediately, the blood sugar peaks around 2 hours, but the insulin will peak around 4 hours. So there is immediately after the food, there is a chance of hyperglycemia, and after around 4 hours after taking insulin, there is a chance of developing hypoglycemia. Okay, so this is the problem when we start treating with a regular insulin as bolus insulin. So now, however, the scientists believe that we got something as bolus insulin. Now we want something for basal insulin. So they incorporated this insulin into certain molecules and made it into NBH. So for acting as insulin, for acting as basal insulin. Because if you see here, when you give 3 boluses before each meal, at midnight around 12 o'clock or 1 o'clock, the action of insulin stops and you give atrapid. But after that, there is no insulin available in our body. So what happens? Gluconeogenesis kick in and lipolysis click in. So what happens? There will be morning hyperglycemia, fasting hyperglycemia will be there. So to prevent that, we needed a basal insulin to be given at night. So that's why they invented NBH. So how NBH? So imagine we get NBH, the action starts within 1 hour, peaks by around 12 to 14 hours, and the action stops by around 18 hours or 16 hours, okay? So if you, what's the problem with let us treat with NBH, okay? So we give NBH at night 10 o'clock. So what happens? The NBH peaks by morning time around 4 o'clock. So that time we are not eating food. So patient will develop a hypoglycemia at 4 o'clock. It's a good insulin to control the fasting glucose because the action will last throughout the night. But when we give it at night time, because the role of NBH is to control the fasting glucose. So we have to obviously give it at night time. So when we give it at night time, the problem is since it has a peak, it will peak at around 5 o'clock in the morning. That time we will be sleeping and will be not taking food. So what happens? The chance of patient developing hypoglycemia at early morning. So what should be the characteristic of an ideal basal insulin? The ideal basal insulin should not have a peak. It should it should not have a peak. It should be the action should be almost a flat line, and there should not be erratic release of insulin in the body. So if there is erratic insulin, there is a high chance of patient developing hyperglycemia. Then suddenly, because of drastic release hypoglycemia, this is called as the glycemic variability. That is found to cause more complications. So that's why there should be minimum glycemic variability. There should not be any, the release should be a constant release, and the duration of action should be more than 24 hours. Because throughout the day, if the action lasts in a constant manner, that is the best characteristic available for a basal insulin. So with this, to tide over this, the scientists started changing the amino acid sequence of insulin to make it more, prolong the duration of action and for making a basal insulin and to shorten the duration of action for a bolus insulin. So that's how we reach the. So when the insulin is injected in our body, this is the regular insulin. When usually it forms a dimers, dimers should be degraded into monomers, and monomers will only be absorbed into our blood circulation, and it reaches the blood circulation, then only it starts acting. Okay. So what they done is after changing the molecular structure of the insulin, the amino acid sequences, they made sure that an insulin can, once injected, can remain as monomers, so that the action will start immediately, and it will peak immediately, and will stop immediately. So it will be an ideal agent for a bolus insulin. And again, what they done is, instead of dimers, they made it hexamers, dihexamers, and multi-hexamers. So once you inject it, they use the pH of our body. So once the pH decreases, and when the insulin reaches a lower pH, it will start precipitating to form multi-hexamers. So once these multi-hexamers are injected in the subcutaneous tissue, it should be divided into hexamers, then dihexamers, then dimers, then monomers. So that there is so much time it will take for the complete release of insulin to be absorbed into our bloodstream. So we can prolong the action of insulin by, so they have done both ways. We needed an ideal bolus insulin, which is shorter action time. We needed a basal insulin with a longer duration of action. So by changing the amino acid sequences, they attained it. That's how they invented the rapid acting insulins like lispro, glucine, and aspartate, which acts almost like the physiological rise in blood glucose levels. The insulin action starts within 5 to 10 minutes of eating food, and the peaks by 1 to 2 hours where the blood glucose level peaks, and the action stops by 4 hours when the blood glucose level drops. So this is an ideal candidate for a bolus insulin. And they, by changing the amino acid sequence, they again delayed the action of insulin for a basal insulin. So what happens is, they invented long-acting insulins like Detimer and Glarginin, and ultra-long-acting insulins like Deglutec and Glargin U300. So with the Glargin U300, with the Glargin U300, the action starts within 30 minutes of injection, and there is no peak at all. It's a constant release throughout the day, and the duration of action, if it's Glargin U300, is around 36 hours, and for Deglutec, it is around 40 hours. So constant release throughout the day for 40 hours. So this is an ideal candidate for a, which insulin? Basal insulin. Because throughout the day, constant release, mimicking the basal secretion of insulin by our pancreas. And this is the rapid acting insulin is an ideal candidate for bolus insulin. This we already discussed. So the best way to manage blood sugars is to, I told you, to mimic the physiological release of insulin by the pancreas. So if you look at this, this is the best way to manage blood sugar in any patient, is to give 3 bolus insulins. That is the best bolus insulin we already told is the ultra short acting insulin like aspartate glucine or aspartate glucine or Lispro. We give it just before each meal, and the blood sugar will rise along with the insulin secretion will peak along with the blood sugar rise, and we can give it 3 times a day before each meal. It will control the bolus secretion. And if you give a ultra long acting insulin like Deglutec or Glargine U100 at night time, the release will be throughout the day for 40 hours. So that will act as a basal insulin. So this is the best way to control blood sugar in any patient, and this is called as basal bolus regimen. Then for our comfort, they have mixed this basal and bolus insulins together in different ratios so that we can, so what's the problem with the basal bolus regimen? How many injections? No response. Please. So 4 injections should be taken every day. So it will be difficult for some patients. So by using the knowledge that some amount of insulin secretion will be remaining in our body in the onset of diabetes, what they done is they mixed this basal insulin and bolus insulin into single unit, and that's called as premixed insulins. So premixed insulins are available as biphasic insulins of Lispro, that is ultra short acting insulin with NPH, that is intermediate acting insulin. So you can give it 2 times a day, morning and night time. So the Lispro in that will take over the bolus secretion, and the NPH will take up the basal secretion. So that's how they, just for the convenience sake, they have invented this. So if in case of a patient is having, the ratio can vary depending upon the 30 to 70. But if in some patients they require a bolus insulin requirement is high. Which patients will have bolus insulin requirement high? PP-based control. The patients who require higher PP-based control, the bolus insulin should be higher percentage. Because basal insulin is one taking care of fasting sugars, and bolus insulin is one taking care of postprandial sugars. So in some of our patients, we told that because high carbohydrate load, they have higher postprandial sugars. In such patients, we can give a 50:50 ratio of premixed insulin. So now get to insulin choice. We already discussed. We have bolus insulins like rapid acting insulin or regular insulin, cost effective regular insulin, and we have fast bolus insulins, and we have long acting insulin or ultra long acting insulins as basal insulins. Just skipping slide. So now how will you initiate a patient coming to your OPD with for insulin? Which insulin method we should prefer? Okay, that's so we have 3 methods of starting insulin. One, we can start the patient on a basal insulin. Patient will be on oral hypoglycemic drugs, and you want to start the patient on insulin. So what we can do is we can start the patient on a basal insulin that will act throughout the day and taking care of their fasting glucose and some amount of postprandial glucose also. So while treating diabetes, what they say is you have to treat the fasting glucose first, because fasting glucose is one that favors hepatic glucose uptake. So if there's increased fasting glucose, there will be reduced hepatic glucose uptake and increased gluconeogenesis, leading to higher postprandial sugars also. So once the fasting glucose is controlled, there will be increased glucose uptake in the hepatic glucose uptake and reduced gluconeogenesis. This will also some amount control the postprandial sugars also. So when you start insulin, always aim for the control of fasting sugars. So basal insulin, very easy regimen, only 1 injection is required at night. Throughout the day, the insulin action will last. It's a very convenient method. And with the ultra long acting insulins like Deglutec or Glargine U100, there is no peak and the chance of hypoglycemia is less. So the patients will be also happy to take that. 1 injection, no hypoglycemia, very good. You can add on with the OHA. Well, one other option we have is to start a premixed or co-formulation insulin, which we already discussed, but the premixed insulin is 2 injections per day. But the advantage is it will take care of the postprandial sugars also, because it has some amount of bolus insulin. Then next is the basal bolus therapy. We already discussed 3 bolus insulins and 1 basal insulin. So for total 4 injections, best method. But the problem is higher chance of hypoglycemia, also you will achieve very good sugar control, but the problem is higher chance of hypoglycemia, and second is 4 injections per day. So now, what's the problem with the premixed insulin? If you give it as morning and night, the noon sugars, at noon time when we take food, that time during lunch, post-lunch sugars, there's a high chance of rising because there's no bolus insulin before lunch time. So when you give it as a bolus, premixed insulin morning and night time, the lunch time there is no bolus, so the post-lunch sugars can rise after lunch time. So what are the guideline recommendations for starting insulin in a patient coming to your OPD? So most of the guidelines now recommend starting the patient on basal insulin, using the fact that it can control the fasting sugars to a very good level, and throughout the day the secretion action will be there, and also there is no chance of hypoglycemia. Especially they are recommending ultra long acting insulins with no peak at all, so there is less chance of hypoglycemia. So most of the guidelines now recommend basal insulin. Till 2014 they were recommending premixed insulin because of the convenience of loose, but now you have better basal insulin, so that they have changed the guidelines. But RSD alone is again still sticking to premixed insulin because of the nature of hypoglycemia in our patients, diabetes in our patients. We already discussed, due to high carbohydrate load, the postprandial sugars is also higher in Indian patients compared to the Caucasian patients. That's why they are still sticking to the premixed insulin. ADA from 2001, they changed the guidelines. They are telling to use ultra long acting basal insulin for starting the patient on insulin. So how will you start the patient on insulin, basal insulin? What are the regimens? So this is a Be Smart. It's a basal early strategy to maximize the HbA1c reduction. This is given by the Indian experts in for control starting basal insulin. What they are telling? So when your patient is coming to you with uncontrolled blood sugars, you start the basal insulin the dose of 1 or 2 units per kg per body weight. So if a patient is having body weight of 80 kg, you start 8 units of basal insulin at night time. If the patient is little bit obese with increased evidence of insulin resistance, you start the patient on 0.2 units per units per kg body weight. That means around 16 or 14 units you can start. Okay? And what you have to do, this is a slow acting insulin, so you have to wait for 1 or 2 weeks to check the fasting sugars. And always basal insulin control the fasting sugars first before checking the postprandial sugars. Since once the fasting sugars are controlled, the postprandial sugars will fall in line. Okay? So after 3 weeks, you check the fasting sugars. The fasting sugars is less than 80, you reduce the dose by 2 units. If the fasting sugar is 80 to 130, within normal range, like accepted range, no dose modification, continue the same dose. If it's 130 to 160, increase the dose that we have given by 2 units. If it's above 180, you increase the dose by 6 units. And then again check fasting sugars after 2 weeks. Okay? This is the guidelines given by the Indian expert committee. And once you achieve the fasting sugars within normal range, and then you do an HbA1c. If the fasting sugars is in normal range of 80 to 130, but the HbA1c is on the higher side, that means it's not the fasting that is favoring the HbA1c, uncontrolled HbA1c, it's the postprandial sugars. Then you start checking postprandial sugars. So you check postprandial sugars after each meal, 2 hours after each meal, and you find out which meal is causing more favoring the HbA1c, which meal is postprandial sugars is very high. You give a bolus insulin just before that meal. That will take care of that postprandial sugars. So this is called as basal plus regimen or 1 meal regimen. So whichever meal is having higher postprandial sugars, you give the basal insulin as such when we are continuing, because the fasting sugars are controlled, and you identify which postprandial sugar is causing the HbA1c rise in HbA1c, and you give 1 dose just before that meal, and this is called as basal. So still 2 injections you can achieve a very good HbA1c reduction. But sometimes 2 meals will be there, you can add 2 injections, just 1 bolus injection before each meal. Whichever 2 meals the postprandial sugars are uncontrolled, you give 2 injections just before that each meal. Okay? So which insulin you prefer to give as bolus? Which insulin? Ideal bolus? So ultra short acting insulin or a rapid acting insulin like a Dispro or glucin, which again peaks with as the blood sugars peak. Okay? But if the postprandial sugars is throughout controlled, you have to go to basal bolus regimen only. Okay? But usually we will get a good control with the basal plus or basal 1 plus. 1 plus means after 1 meal, or basal 2 plus basal means after 2 meals. Okay? This is the way they are recommending to control hyperglycemia in patients who are. This is the AZEEZIA algorithm, recent AZEEZIA algorithm. They are also now switching to stepwise approach of insulating insulin. So how much basal bolus insulin you will give? Around 10% or 20% of the dose of the basal insulin we are giving, you should add as a bolus insulin. Preferably we can give 5 units or 6 units just before the meal, that is contributing the postprandial glucose. So in some, even though the ADA is recommending this, our case scenario is a totally different. We already discussed in Indian patients, mostly it's not only the fasting glucose, the postprandial sugars also can be uncontrolled. Okay. So in another, the another option there is, instead of adding a basal regimen, basal bolus plus regimen, but the Indian expert recommended something called adding a pre-mixed insulin just before that meal. Okay, pre-mixed insulin, that is having ultra short acting insulin and ultra long acting insulin before the meal, that is contributing to the postprandial sugars. Okay, so how to identify which insulin to add? If the postprandial glucose exertion, that means the fasting glucose minus or the pre-meal glucose minus the post-meal glucose, if it's more than 74%, that means the more the postprandial sugars is favoring because it's after the taking food, the sugar rise by 74% milligram per deciliter. In such case, you can add a rapid acting insulin just before the meal or a pre-mixed 50-50 insulin with a higher bolus load before that meal. But if it's in the 40 to 74 range, you can add only pre-mixed insulin, that is around 30 to 70, 30 in the ratio of 30-70 before that meal. But when to add a basal insulin, better to add a basal insulin when the postprandial exertion, that is before and after the meal, the exertion is less than 40%, you can add a basal insulin. This is when the basal insulin works very well in Indian patients. This is for Indian scenario. So I'll just skip the slides. This is one drug which will act in one case of a basal plus regimen. The best drug to add is idesparspatide, where it has they have made the combination of ultra long acting insulin, that is the best basal insulin, and ultra short acting insulin aspartate as a bolus insulin. They are mixed into a single vial. So if you give it just before the meal, that is contributing for postprandial sugars, higher blood sugars and higher HbA1c, it will work very well. So managing hyperglycemia in hospital, this was the hospital setting we have discussed. Now managing hyperglycemia in hospital setting, I will now skip the critically ill patients, because critically ill patients, once now they are telling is when the blood sugar goes above 180 to 250, you start the patient on insulin infusion. Okay. So that I am not going, I am going to the non-critical ill patients who are admitted in ward or in ICU who are non-critical. In such patients, how will you manage hyperglycemia? The previous, it was a sliding scale which is outdated. Now, because why sliding scale is outdated? Sliding scale is a fixed dose is given for fixed sugars. So what happens when the patient's sugar is around the range of 300, if they give an insulin, the next sugar will be 100. So that time means according to sliding scale, you don't have to give insulin. So what happens? They will skip the insulin, but the next sugar will go into around 400. So these things keep on happening. 300 they given insulin, next shot will be, the next sugar when they check it is 100, they will not give insulin, next sugar will be jumping to very high levels. So this keep on happening, that's why the problem is sliding scale. So they have now not approved sliding scale. So instead of what they are telling, the best way to control sugars in patients is to give a basal bolus regimen. How to give a basal bolus regimen? You calculate the total dose requirement. How you calculate the total insulin requirement per day? That is in a lean body individual, the total insulin requirement will be 0.4 to 0.5 body per kg unit. Or in a patient with a higher insulin, in a lean is a 0.3 to 0.4, and in obese patients, because of higher insulin resistance, is 0.5 to 0.4 to 0.5. You multiply this into body weight, and you divide the values what you get into to 50 as basal and 50 as bolus. Understood? So, lean individual, less insulin resistance, so 0.3 to 0.4 units per kg into body weight. Whatever value you get, divide it into 3, divide it into 2, 50 into basal insulin and 50 into bolus insulin. The bolus insulin dose you divide into 3 and give it before each meal. That's how you have to control and the basal insulin you give at night time. Ultra long acting insulin and ultra short acting insulin, the bolus insulin can be divided into 3 and given before each meal. So this is the best way to control hyperglycemia in inpatient setting. So then you should add a correction factor. Correction factor is because patients might be developing, will be giving steroids. So when we give steroids, the sugars immediately after giving a steroid will be always on the higher side. So sometimes when you check, even after starting like this, when you check the blood sugar values, it will be, some of the values will be on higher side. To tide over that higher sugars, we have to give a correction factor. So how will you calculate the correction factor? For regular insulin, for rapid acting insulin is 1800 divided by the total insulin dose that we calculated by 0.2 unit into body weight. That much you have to divide 1800, and whatever factor you get is a correction factor. Correction factor is a value that shows that in that patient 1 unit of insulin will reduce this much amount of sugars. That is the correction factor. Now what you do is you calculate the correction dose. Using the correction factor, you calculate the correction dose. How will you calculate the correction dose? So now whatever the blood glucose you got before the meal minus the whatever blood glucose you expected. In case of lunch time, the blood glucose you got was 250. Okay, blood glucose you expected is 150. You minus 250 minus 150. 100 is the value you get, and you divide the total the correction factor from 100. So whatever dose you get there, you add that along with the dose that was previously available. So that's that you tide over the insulin correction. Or you can use a fixed correction protocol they have given. Okay, that they have already given. But the better way is by calculating how much 1 unit of insulin will change, reduce the sugars in that patient, and then correct it accordingly. So, but I told giving ultra short acting insulin very costly, 3 times a day. Then ultra long acting insulin like degludec costs around 2000 at night time. So the overall cost will be very high. So one alternative we can use is we can use a not ultra long acting insulin like glarginin as a bolus dose, as a basal insulin, and ultra short acting insulin as bolus insulin. Or we have our own tried and tested our own method of controlling blood sugars with the NBH and regular insulin, where you can give 3 shots of regular insulin just before the meals and 2 shots of NBH at morning 8 and night 8 time. This is also a cost effective method, but it's on difficulty. The problem is by 11 AM, the almost NBH also about to peak, and the atrapid also peak. That time high chance of hypoglycemia. Again at midnight also the same. By 5 AM there is a high chance of hypoglycemia. This, okay. Thank you.
So it was a very nice presentation. The kind of essence of your kind of professional as well as academic acumen was there in every slides.
Thank you.
Okay. And moreover, I think this is a perfect message for the students. Basically, when you being students, you go always behind reference ranges and everything. But if you want to become a doctor with a professional acumen, you should also set your mind regarding the treatment targets. So in this very stipulated time, you have managed to show almost everything actually regarding this thing. So I hope you will be, you have got something from this, okay? And moreover, I also expect you to move forward with the, you have to revise these things, whatever small things you get from this slides or the session, okay? And I should add one more thing actually. You're telling about our glycemic control things and everything, and the glycemic control marker we usually mostly depend is HbA1c also.
Yes, yes.
And proudly I am telling, last month our Department of Medicine of AZEEZIA Medical College has diagnosed a HBD Punjab case. I hope you also came to know about it, because in the sense of laboratory medicine field, every glycemic control marker is not reliable for everyone. Even the ADA guidelines also say so.
Yes.
Last month, actually, Department of Medicine of AZEEZIA Medical College has seen a case that has been sent to the lab for an HbA1c diagnosis, and we have found there is a good percentage of HBD Punjab in it. And for that patient, HbA1c was not should not be considered as a reliable glycemic marker also. That means today, Dr. Amit has given you a fire. You have to make it a wildfire. That is the main thing. So from my suggestion, you have to take forward the readings to Dawn phenomenon as well as Somogi phenomenon, all those things. Okay. Very short time, he has presented almost everything, actually. It's very good presentation. Thank you, sir.
Thank you.
It's open for the questions.
it was mentioned that in critically ill patients, it is advised to start on insulin infusion therapy. But patients who are in sepsis are also at increased risk of going into hypoglycemia, which is also poor prognosis, it's increased risk of morbidity and mortality.
Yes.
So is there any guideline which...
Now in critically ill patients, what they are telling is don't aim for a very high glycemic control because hypoglycemia is found to be more deleterious than hyperglycemia. So now they relax the cutoff in critically ill patients. So up to 200 of fasting sugars is okay. 180 preferably, but 200 is okay, not like 160 or 140 where we name patients we aim. And in fasting sugars up to 140 is okay. So don't aim for less than 100. In young patients, what other all guidelines are telling, young patients no comorbidities, you aim for less than 100 fasting or less than 110 fasting. And postprandial 1 hour is less than 40 and 2 hours around less than 160, that will be better. But in critically ill patients, don't aim for so much tight control because it has been found that hypoglycemia is more deleterious than hyperglycemia. But if the blood sugars, but some of the guidelines say blood sugars above 200 or 250, you start the patient on insulin infusion. Give the insulin infusion for 24 hours, to calculate the total insulin requirement per day for the patient, then you divide it into subcutaneous dose and give as basal bolus regimen. That's what most of the guideline agencies are saying. Because the advantage of IV insulin is once you stop the insulin infusion, within few minutes the action of the insulin stops inside the body. Not like subcutaneous insulin. Once you inject it, most of the sepsis patients, their pharmacokinetic, pharmacodynamic properties will be erratic. They will be hypoalbuminemia or renal failure, their GFR will be reduced, or they will have multi-organ dysfunction. So once you given the injection subcutaneously, we cannot predict it like normal persons. So that's why they are recommending IV insulin. IV insulin, if you stop the insulin infusion, within few minutes the action stops. That's why in most cases, before stopping the IV insulin, you have to give a subcutaneous dose 20 minutes before. Because once you stop the IV insulin, immediately the gluconeogenesis starts kicking in, especially in patients who are having absolute insulin deficiency. Lipolysis starts, gluconeogenesis starts. That's why when you start stopping insulin infusion, give 20 minutes before you give a subcutaneous dose, then you stop. After 20 minutes, you stop the IV infusions. By the time the subcutaneous insulin will start acting.
Thanks.
Dr. Amit, this is a very good presentation. So very, very extensive presentation, covering almost every area. Just one couple of questions. What is the is HbA1c a reliable marker for glycemic variability?
Sir, HbA1c is not at all a reliable marker for glycemic variability. One problem is in anemia we cannot relay it. Second is, if the I rarely use it unless for diagnosis of diabetes and only in people who are very uncontrolled. Because most of our patients, they will take a feast, they will go to one marriage or some party, they will take some food. So every weekly they will go to one marriage, or every month 1 or 2 marriages, they will have some poison there. So this will be reflected in the average value of HbA1c. So we cannot tell that ideally is whether a good controlled marker. Only for diabetes, we personally use it for diagnosis or some preoperatively to prove that this patient is having a history of uncontrolled diabetes. In such cases only I personally use HbA1cs. But in other cases, because of this many variabilities are there. Now what they are telling is continuous glucose monitoring. Multiple methods have came up now. It's available in India also. That is the best method to monitor a patient's glucose control. And one more, sir. Yes, sir. No, sir.
And the second question is, why don't you advocate this insulin pump when you take into account the cost of all those long-acting insulins?
Why don't we advocate the insulin
yes,
pump?
yes.
Yes, sir. Insulin pump can be advocated, sir. But the only problem is they should have some basic knowledge about managing this insulin pump, because they have to calculate the carbohydrate load for each meal and give a bolus insulin just before the meal. So if they are very familiar, it's a very good method to control. Only problem is again insulin pump is also costly. That dose, that patch they have to change. That one, the pump is also costly. It usually costs around more than 1 lakh rupees. So the initial cost, most of the patients prefer. Others, it's a very good.
For continuous glucose monitoring, do you use the ambulatory glucose profile or the CGM?
Ambulatory glucose profile is also okay, sir. Or now, but they are telling is CGM is a better. Then, or we can use 8-point sugar monitoring, depending on the patient convenience.
Do you have it here, Dr. Hari?
CGM, sir?
CGM?
Not so.
CGM, if we call them, they will bring it, sir. The mission, now lot of people, in Tibetan they are having here, so they will make the mission, sir.
I remember that we have called multiple times, they didn't turn up.
Okay, sir.
Anyway, sir, to add on the HbA1c, sir, because as you told, HbA1c reliability is an issue.
So that's why in terms of laboratory medicine only I'm telling, okay, they have considered certain technologies like HPLC as well as the capillary electrophoresis being good for this. Because in the blood, apart from HbA1c, other pro-glycated kind of hemoglobins are also there. Starting from HbA1a, A1b, and even the labile A1c, who is the most recent factor fellow. And these fellows, and even the sample degradation factor named P3. Certain 10 factors are there. So a reliability of a HbA1c, of a person's HbA1c level depends on these factors. And if these factors are abnormal, this patient's HbA1c may not be considered as a glycemic control for particular patient. And the value of these factors will be only known if the HbA1c is done in this kind of HPLC or capillary electrophoresis method. Moreover, other physiology factors like, as you know, the extremities of the ages, and even there are cases suggesting the use of aspirin has increased the concentration of a thing called acetylated hemoglobin, which is something like HbA1c, which mostly the assays may not differentiate them from HbA1c and this kind of acetylated the HB.
Now some of the hospitals are using that also, sir, acetylated. I think some of them are using acetylated, other methods for HbA1c.
Exactly. When we are doing in HPLC method, there is a thing called LA1E2 curve. If that percentage is increased, that means the person is having more acetyl HbA1c. So in this kind of, if the percentage is very low, it's okay. But if the percentage is affecting, it's in terms with the total hemoglobin concentration, which is given on the graph itself. If it is near or more than that thing, that means for that person, HbA1c should not be considered. Of course, the main factor is, which Dr. Amit already told, that is the anemia, especially the hemolytic anemia part of it. Yes.
Globin can produce an increase in the HbA1c.
Yeah, it is. Polycythemia is also considered.
Yes.
Actually. And moreover, it's a recent study. I think once some of the PGs can also take it up. Iron deficiency anemia can falsely increase HbA1c.
Exactly. Yes.
It is also there. Minimum 0.5%. Minimum 0.5%.
There are patients with hemorrhoids, or let's say, for example, with peptic ulceration and lose blood, you get a spuriously elevated HbA1c. Once you correct the underlying risk factor, it gets continuously correct. Exactly. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Amit sir, for that comprehensive and practically relevant session. Now, I invite the chairs to hand over the memento and the certificate to the speaker, Dr. Amit sir. I now invite Dr. Joseph Vinu sir, Senior Consultant Nephrologist, Holy Cross Hospital, Kottayam, to hand over a token of gratitude to Dr. Srikandan sir. I also invite Dr. Afzal K. Azad sir, Consultant Family Physician, Royal Hospital, Chatanu, to hand over a token of gratitude to Dr. Hari sir. Now, we have a short presentation from Team GSK.
check, 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 hello, check, check, hello, check, hello, check, 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 hello, check, hello, check.
Check, check, check.
Check, check, hello.
We are now ready to move on to our next session. Silent Invaders, Unmasking Hospital-Acquired Infections. Hospital-acquired infections continue to pose a significant challenge to healthcare systems worldwide. When healing places become breeding grounds, hospital-acquired infections step in. They often remain undetected, silently complicating patient care and extending the recovery period. Preventable, yet still persistent. Chairing this session are our two distinguished individuals. Dr. Amit Sir, our respected physician known for his outstanding clinical skills. Dr. Prashobh Sir, Professor, Department of Microbiology. We invite the chairs to the dais. To shed light on this critical topic, we are honored to have with us Dr. Reshma R. Pillai ma'am, Assistant Professor, AZEEZIA Medical College, Kollam. I invite Dr. Reshma R. Pillai to the stage.
Good afternoon, everyone. It's a privilege to be here. Good afternoon, everyone. It's a privilege to be here today to discuss hospital-acquired infection, something we see in our wards and ICU, but often it is underestimated in terms of its impact and preventability. So, today we will be going through these subheadings. That is, what are hospital-acquired infections? What are the most common types of hospital-acquired infections? What are the primary risk factors? And what role does microbiological diagnosis play in managing hospital-acquired infections and how to manage, and lastly, infection prevention and control strategies. Basically, hospital-acquired infections is defined as infections that manifest after 48 hours of admission that are neither present nor incubating at the time of admission of the patient into a healthcare facility. And when it comes to why we need to discuss HAs, HAs are common adverse events during healthcare delivery, and it is a major health issue affecting morbidity and mortality, and also it affects the quality of life and patient safety. And it also prolongs hospital stay, and it leads to long-term disability and increased resistance to microorganisms, and also it increases the cost on health system and both on the system and the patient. And now about a few, it's a major concern in all countries because it is, according to the new statistics, it is estimated that of every 100 hospitalized patients, 7 in high income and 10 in low and middle income countries will acquire at least one healthcare associated infections. And when it comes to ICU, the percentage increases to about 30%. And something very concerning is that in that infection, a quarter of, that is 1 in 4, healthcare associated infections in long-term acute care settings are caused by resistant microorganisms. Now, coming to the types of healthcare associated infections. First is bloodstream infection, usually associated with the catheter, and we have urinary tract infection, that is usually catheter related, and ventilator associated pneumonia, surgical site infection, and GI infections. Next, following are the risk factors which we keep in mind when we are dealing with hospital-acquired infections. That is age. One is prolonged use of invasive devices like catheters and ventilators. Then immunocompromised states like uncontrolled diabetes and malignancy. and also the age, extremes of age like elderly patients and newborns or infants have less robust immune responses, making them more susceptible to hospital-acquired infections. And also the poor hand hygiene and inadequate sterilization practices, and also the inadequate and irrational use of antibiotic leading to antimicrobial resistance, and inadequate training of the healthcare workers, and other risk factors for the hospital-acquired infections are the patients who undergo surgeries. Now, let's now look at each healthcare-associated infection briefly. First, healthcare-associated bloodstream infections. Healthcare-associated bloodstream infections accounts for high mortality, and it is usually associated with the intravascular catheter. Both central and peripheral lines are source of infections, and all these depends on the care which was taken during the insertion of the catheter, and also maintenance and handling of the catheter, and also depends on the duration of the catheter. Now coming to the criteria of the catheter related bloodstream infections. According to Infectious Disease Society of America, the definitive diagnosis of catheter related bloodstream infections is patient should have clinical signs and symptoms of an infection, and also patient must satisfy any one of the above following three criteria. These are the three criteria, that is identification of the same organism from one or more percutaneous blood culture and from the catheter tip, and then you need 2 blood cultures which are drawn from catheter hub and 1 from peripheral line that meet catheter related bloodstream infection criteria for quantitative culture or differential time to positivity. What is differential time to positivity? Differential time to positivity supports the diagnosis of the catheter related bloodstream infection. It is when the catheter drawn blood culture becomes culture positive more than 2 hours earlier than the one in peripheral blood. That is differential time to positivity. That is, it supports catheter related bloodstream infection. And next, the other criteria is the 2 quantitative blood cultures which was drawn through 2 catheter lumen cultures where the colony count for the blood culture through 1 lumen is more than 3-fold than the colony count of the blood obtained from a second lumen. That is the difference, colony count should be 3 times more than in 1 lumen. If the patient satisfies any one of the following criteria, it supports the diagnosis of catheter related bloodstream infection. Now the common organisms that is encountered in catheter related bloodstream infection, that are common organisms are Coagulase negative Staphylococcus aureus, Enterococci, then gram negative bacteria, E. coli, Klebsiella, Enterobacter, then you can get also Candida species. Now after catheter related bloodstream infection, next important which accounts for high case fatality rate is the ventilator associated pneumonia. And suspect VAP if there is new or progressive radiographic infiltrates in a patient who is ventilated, and also there is 2 or more of the following features are present. That is, one is patient should have fever more than 38 degrees Celsius and leukocytosis more than 12,000, or leukopenia less than 4,000, and purulent trachate secretions and worsening oxygenation in terms of increasing PEEP or FiO2. You can also make use of supportive tests like chest X-ray, then CBC with differential, and also lower respiratory tract cultures. Preferred one is the endotracheal aspirate. Now coming to the next the most common hospital acquired infection, that is UTI, and it accounts for 35 to 40% of all the hospital acquired infections, and usually it is associated with an indwelling urinary catheter. And the criteria for the catheter associated urinary tract infection is a UTI where an indwelling urinary catheter was in place for more than 2 days, or within 24 hours of catheter removal, or in a setting of an intermittent catheterization, and also the patient must have symptoms of UTI and a positive urine culture with 1 or 2 species of microorganism identified, at least one of them should be more than 10 raised to 5 colony forming units. So patient should satisfy all of the 3 criteria to diagnose it as a catheter-associated urinary tract infection. Now that we have discussed the specific types of hospital-acquired infections, now we will be moving on to the role of microbiological diagnosis in hospital-acquired infections. We have rapid diagnostic test and also conventional diagnosis methods. The rapid diagnostic methods are, we have molecular diagnostic methods like PCR and also MALDI of MS, that is matrix assisted laser desorption ionization, time of flight mass spectroscopy, and then NAT, then automated blood culture systems like Versatec, BACTEC, and you can use lateral flow assays and also biomarkers. And the conventional diagnostic methods are microscopy, culture techniques, and biochemical identification and antibiotic sensitivity testing. Now we will see what is the advantage of the newer techniques in diagnosing hospital-acquired infection compared to the conventional ones. Faster turnaround time. Usually, MALDI can identify bacterial and fungal species directly from culture plates in as little as 10 to 15 minutes, and most often it gives result within 1 to 2 hours. And also, automated blood culture systems can provide results within 12 to 16 hours. And second is the improved sensitivity and accuracy of these new techniques. That is, automated blood culture systems gives sensitivity of about 60%, which is compared to 48% in the conventional techniques. And early identification of the species can lead to appropriate use of the antibiotics, and also we can tailor down the antibiotic use. Now then cost and resource efficiency. Though the initial setup of the MALDI offers there is high cost, the subsequent reagent use and the manpower is significantly lower, and in high volume laboratories it will be cost effective. Now coming to the management of the specific hospital-acquired infections. We are turning into the management protocols. First is catheter-associated urinary tract infection. The general principles for treating catheter-associated urinary tract infection are, for all patients with the symptomatic UTI, treatment is warranted. And the empirical therapy is based on the local susceptibility patterns, and we should use broad-spectrum antibiotics. Once we can tailor down the antibiotic, once the antimicrobial susceptibility testing is available. The usually given antibiotics are you can give ceftriaxone or fluoroquinolones, and if the enterococcus or pseudomonas is suspected, you can empirically start on piperacillin tazobactam. And in regions where there is high prevalence of extended spectrum beta-lactamases, you have to give vancomycin or linezolid. That's about the treatment of the catheter-associated urinary tract infection. Now coming to the ventilator-associated pneumonia. And here also the empiric antibiotic regimen is based on local epidemiology, severity of the illness, and the risk factors for the patient's MDR pathogens. And usually the empiric therapy is designed to target Staphylococcus, Pseudomonas, and other gram-negative bacteria. Usually the empiric therapy includes piperacillin tazobactam or cefepime or levofloxacin or a carbapenem. For patients with risk of MRSA, you add vancomycin or linezolid. And for patients with more than one risk factor for MDR pathogens, consider 2 anti-pseudomonal antibiotics from different classes. So this is the general outline for the management of the ventilator-associated pneumonia. Now coming to the treatment of the catheter-related bloodstream infection. So the empiric therapy of the catheter-related bloodstream infection is designed to treat Staphylococcus, Pseudomonas, and other gram-negative bacteria. Typically, we use vancomycin and a 4th generation cephalosporin or a carbapenem or a beta-lactamase inhibitor. And in patients with neutropenia or severe sepsis, you can add anti-pseudomonal antibiotics. And In patients with a high risk of MRSA, you add vancomycin and linezolid also. And the empiric antifungal therapy is warranted if the patient is on total parenteral nutrition, if the patient has hematological malignancy, or patient has underwent bone marrow transplantation or other solid organ transplantation, or there is femoral catheterization. So this is the management protocol for the catheter-related bloodstream infection. Now, coming to the guidelines for the indications of the catheter removal in catheter-related bloodstream infection. Actually, long-term catheters should be removed from patients with catheter-related infection, and if there is severe sepsis, or there is suppurative thrombophlebitis, or there is endocarditis, or persistent bloodstream infection despite 72 hours of effective antimicrobial therapy. And also catheter removal is warranted if the organism identified is Staphylococcus aureus, Enterococci, fungus, or mycobacteria. And if you want to retain the catheter, consider only if no alternative vascular access or removal of replacement has high complication risk. Or if you are planning to retain the catheter, you can use a antimicrobial lock therapy. This is antimicrobial lock therapy is something you instill very concentrated antibiotics like vancomycin, gentamicin into the catheter, and you allow it to sit there for hours before using the catheter. And along with the antimicrobial lock therapy, you have to use systemic antibiotics. If local antibiotic lock therapy is not possible, you have to give systemic antibiotics via the central catheter. Now the hemodialysis specific recommendations for the catheter retention. Usually in catheter related bloodstream infection associated with the hemodialysis catheter, removal and placement of temporary catheter is recommended, and alternate options, if there is no accessitis, you can try guide wire exchange of catheter, and also you have to place long-term catheters only when the culture results are negative. Now we have seen the diagnosis and management protocol for the hospital acquired infections. Now coming to the main part, that is the infection and control program. A significant proportion of these infections are preventable by sorting into the antiseptic precautions and our control programs. One is why prevention matters, because hospital acquired infections are of high burden, and it increases the morbidity and mortality, and it has got high economic impact. And also considering the lethal and ethical responsibility, you have to follow the preventive measures. One is IPC program. What is an IPC program? An infection prevention and control program is a systematic evidence-based approach designed to treat and control the spread of infection within the hospital. A well-organized IPC program is a basic requirement in the every healthcare facility to decrease the spread of infection. And this is an outline given by the Government of India for an effective IPC program. That is, it should have policies and guidelines. Then a hospital should have well-functioning hospital infection control committee. Then you should have continuous and adequate supply of PPEs. Then you should, every hospital should have a antimicrobial use policy and a antimicrobial stewardship program. And you should also follow the national guidelines for IPC. And you should have a team for HA, hospital acquired infection surveillance, and also a microbiology support, laboratory support, and you have to evaluate the program adequately, and also monitor the activities of the IPC program. And lastly, it should be well implemented through multimodal approach. These are the guidelines put forward by the Government of India for a proper functioning of an IPC program. And also Government of India has given some standard precautions for the control of the infection. One is the hand hygiene. We all know the importance of the hand hygiene. This is one of the important measures to decrease the hospital-acquired infection. And also the proper use of personal protective equipment and also the respiratory hygiene, prevention of injuries from sharp and safe handling of patient care equipment, and also we should strictly follow the principles of asepsis. Now coming to the few strategies for the prevention of ventilator-associated pneumonia. That is, while maintaining the respiratory therapy equipment, you use only sterile, individually packed, disposable equipment, and also rinse reusable equipment in sterile water and dry before each use, and replace disposable items after each use. And while the suctioning practices, use sterile techniques for suctioning and change suction catheters between patients and avoid routine changing of in-use catheters unless visibly soiled or malfunctioning. And also you should avoid filling nebulizers with tap water. Use only sterile fluids for nebulizers and humidifiers, and change nebulizer solutions every 24 hours. There are additional preventive measures like you have to elevate the head of the bed to reduce the aspiration risk, and also you have to give regular oral care with antiseptics, and also you have to minimize the ventilator circuit disconnection. These are the strategies put forward to prevent the ventilator-associated pneumonia. Now coming to the strategies to prevent central and associated bloodstream infection. These are education and training of healthcare workers, then strict hand hygiene, use of maximal sterile barrier precautions, and adequate skin antisepsis before catheter insertion, and you have to select optimal insertion site. That is, upper extremity is preferred more than the lower extremity. Now coming to the strategies for the prevention of catheter-associated urinary tract infection. That while insertion, wash hands thoroughly or use alcohol-based hand rub before insertion, and also you have to use sterile gloves and aseptic technique, use appropriate catheters and lubricants, and also catheters should be properly secured and positioned after insertion. For the maintenance, you have to maintain a closed drainage system and replace catheter and drainage system if connection or leakage occurs. Keep the drainage bag below the bladder to prevent the backflow, and avoid routine changes of catheters or drainage bags. These are the general outlines given by the Government of India to decrease the catheter-associated urinary tract infections. Now a few words about the antimicrobial stewardship program, which is an important aspect of the IPC program. That is why we should have an antimicrobial stewardship program, because of the rising trends in the antimicrobial resistant pattern. Resistance to E. coli to third generation cephalosporin has raised from 70 to 82%, and resistance to carbapenems is increased from 30 to 33% over the last 10 years. And also 60% of the gram-positive cocci became resistant to cephositin, which is a surrogate marker for the methicillin resistance. And also 1% of the Staph aureus and 5% of the Enterococcus become resistant to linezolid, and 16% of Enterococcus become resistant to vancomycin. This is the latest statistics. Now, what is antimicrobial stewardship program? Antimicrobial stewardship program is a coordinated set of actions designed to promote the responsible use of antimicrobials, ensuring optimal selection, dosing, and duration to achieve the best clinical outcome while minimizing the side effects and the resistance. Every healthcare facility should establish a effective antimicrobial stewardship program, or it should have an antimicrobial stewardship committee. And it should develop and implement standards, treatment guidelines also, and develop antibiotic policy for optimizing antimicrobial use. That's all about the IPC control program. And take-home messages is hospital-acquired infections are preventable with strict adherence to infection control practices, and hand hygiene is the single most effective measure to reduce its transmission. And early identification and appropriate isolation can limit spread and improve outcomes. Environmental cleaning, device care, and staff education are key pillars of prevention. A multidisciplinary approach involving all healthcare workers is essential for its control. Okay. Thank you.
That is a very precise talk by Dr. Reshma. So I have one question. What's your experience regarding seeing hospital acute or hospital onset Clostridium difficult infections, especially when we treat such patients with higher end of antibiotics?
Actually, the incidence of hospital acquired Clostridium difficile infection is towards the rising trend towards the recent years because of the use of the broad spectrum antibiotics, especially the clindamycins and the cephalosporins. And usually it presents with fever, and also it presents with diarrhea, that is more than 3 episodes of loose stools over the 24 hours, and we treat according to the severity of the infection. And for the diagnosis, we can use the identification of the toxin using NAT, and also we have GDH assays, that is glutamate dehydrogenase assays. And also you can treat it with fidaxomicin or oral vancomycin. And also if it is severe, you can give oral vancomycin and IV metronidazole.
You are given told that ceftriaxone can be given for hospital acquired urinary tract infection. But in our place, we see a lot of resistance to ceftriaxone even for other inherent infections.
That is, I specifically said that is the selection of the antibiotic is based on the local susceptibility pattern and the epidemiology.
We are seeing a lot of CREs nowadays also. These escape organisms, these are the organisms we suspect when we have a hospital acquired infection.
Thank you, Dr. Deshma, for the wonderful presentation. An appeal to the young budding doctors, your request forms to be written completely. Because most of the times, we are feeling the difficulty to call the doctors like Dr. Amit, Dr. Deshma, Dr. Jas, and they ask about the patient history and all. So the budding generation should be care about filling the request forms properly, then only we can able to find out whether the patient is on catheter and all the things. So it is open for the discussion.
Ma'am, what's the role of this organisms that cause biofilm formation?
Actually, biofilm formation is particularly seen in catheter-related bloodstream infections, and it is very difficult to treat. So in guidelines, it is recommended to remove the guidelines, or in recent studies, it has been shown that for the better isolation of the catheter-related bloodstream organism causing catheter-related bloodstream infection, you have to take the first blood that is taken through the catheter. Usually we used it to discard the first drawn sample from the catheter for the cultures. But in recent studies, it has been shown that it will yield more organism than the earlier method.
So ma'am, in all cases with biofilm formation, it is indicated to remove the line, invasive line, or
No.
can we keep in place?
If the catheter can be removed, it is better, because antibiotic penetration is less in biofilms. Okay, if the catheter can't be removed, we can use an antimicrobial lock therapy. That I have said, that is, it is the installation of the highly concentrated antibiotics into the catheter, and it is left in place for hours before the use.
This biofilm formation, you have to remove the catheter, otherwise it will not work actually. For this antibiotic lock therapy, you should reinsert another catheter should be there for the locked antibiotic. Otherwise, so biofilm, it will remain there because that substance is an artificial substance we introduce inside. So it will not have inherent cell-mediated immunity. So you have to remove the catheter.
Sir, it was mentioned that some organisms, it is very much recommended to remove the line, as in case of Staph aureus, Enterococcus. So is it because these organisms have increased propensity for biofilm formation, or is there any other cause?
That I am not sure how to refer. Usually when we say about the hospital acute infections, we call these organisms escape organisms. Enterobacterus, Enterococcus, Streptococcus, Pseudomonas aeruginosa, Klebsiella. We call it just together as escape organisms. These are the organisms that usually cause hospital acute infections. So this particular question, I am not sure whether these organisms have any role in
It
this.
is advisable to remove the catheter if the organism identified is the Staphylococcus aureus.
Thank you.
no more questions, we'll mark the session as closed.
Thank you, Dr. Reshma ma'am, for that enlightening and well-delivered session. Now I invite the chairs to hand over the memento to the speaker. We invite Dr. Ijaz Mohammed, Assistant Professor, Department of General Medicine, AZEEZIA Medical College, to hand over a token of appreciation to Dr. Amit sir. We invite Dr. Sanju Daniel John sir, Associate Professor, Department of General Medicine, Apollo Hospital, Angamali, to present a gift to Dr. Prashop sir.
As we move into the next session, we focus on a common yet clinically significant topic, evaluation of edema in adults. Edema is often just the visible tip of a complex iceberg, reflecting underlying disturbances in renal, cardiac, hepatic, or nutritional status. From the feet to the face, edema makes its presence known, sometimes subtly, sometimes urgently. Chairing this session, we have Dr. Sanju Daniel John sir, Consultant Physician, Apollo Hospital, Angamali, and Dr. Deepa ma'am, our Consultant Nephrologist, AZEEZIA Medical College, Kollam, known for her deep expertise in renal medicine and her patient-centered approach to complex clinical problems. We are honored to have with us Dr. Joseph Vinu sir, a distinguished consultant nephrologist at Holy Cross Hospital, Kottayam, to shed light on this important subject.
Hello. Good afternoon. I think we have come to the post-lunch session, the last topic. So here we have the topic of edema evaluation in adults by Dr. Joseph Vinu. Dr. Joseph Vinu, please carry on.
Thank you, sir. So I am the last man standing. The last batter is here. But as we say, the match is not over until the last ball is bowled. So the theme of this CME was deciphering clinical signs. So I thought I would go for a basic clinical sign, which is edema. And I would be dealing the topic in the following headings. I would first tell you what is edema, how does edema form, and what all conditions edema form, and what you should do when a person comes with evaluation, and some things about a condition called as idiopathic edema, followed by a short summary. So what is edema? Edema is defined as the palpable swelling produced by expansion of interstitial fluid volume. When it involves the legs, we call it pedal edema. Sometimes it can, rarely it can involve the arms alone or the face alone. Sometimes it can involve the whole of the body, in which case we call it as anasarca. And many a times it is a pitting. What does pitting means? When you apply pressure, the fluid in the interstitial, the fluid in the area of pressure which we have applied, it will shift. That is called pitting. And most of the edema are pitting, and some of them are non-pitting. Now coming to classification of edema, it has been divided according to the location of edema. That is, it can be either peripheral, sometimes in the leg alone, sometimes or rarely in the arms alone, or sometimes all over the body, in which case it is called anasarca. Sometimes it can present as isolated pulmonary edema, that is edema of the lungs, which is a life-threatening condition. Most of the time it is cardiogenic in nature or due to severe kidney failure, or sometimes you should consider non-cardiogenic causes like ARDS also. The third one is a localized form of edema, which is ascites, that is accumulation of fluid in the abdomen, which has its own important causes. Then there is the other types of edema, which is lymphedema. Initially, lymphedema is also pitting, but there is another type of edema called mixed edema, which is not pitting, and some localized forms of edema called periorbital and scrotal edema. But periorbital and scrotal edema usually occurs in combination with a generalized edema. It is very, very rare to have edema of the periorbital region or scrotal region in isolation, which is most commonly due to an infection or an inflammatory disorder. Now let's see how this edema occurs. You must have seen this picture which describes the Starling's forces which acts on the capillary. You have the arterial end of the capillary and the venous end of the capillary. The blood is flowing through the capillary. The hydrostatic pressure of the blood acts to drive the fluid out of the capillary. The oncotic pressure of the capillary of the proteins will try to absorb fluid from the interstitium. And whatever fluid has been filtered from the capillary will be carried back into the circulation through lymphatics. So alteration in this capillary hemodynamics can cause edema. In the arterial end of the capillary, there is a sphincter which is auto-regulated. So increases in systemic blood pressure is not transmitted into the capillary. So hypertension usually does not produce edema. However, at the venous end of the capillary, it is not regulated. So venous obstructions or increased venous pressure like in heart failure can be reflected back onto the capillary, resulting in increased edema fluid formation. And the oncotic pressure in the capillary will be reduced in conditions which cause hypoalbuminemia, or either due to decreased synthesis or loss in urine. And you should not forget that the capillary, the amount of fluid is just filtered also depends upon the surface area and the permeability. So in conditions which cause increased permeability, like in burns, which causes some in burns, in inflammatory conditions, when you are treating with interleukin 2 or anti-VEGF, in ARDS, in these conditions the permeability increases and edema formation increases. And as the fluid moves from the interstitium to the circulation through the lymphatics, these lymphatics can be occluded, especially when there has been lymph node dissections or radiation, or when there is filariasis. So all these are the main causes of edema. These are the disturbances which can occur in capillary hemodynamics. But this is not enough. So because the fluid will be returned back to the circulation by the lymphatics. In addition to this, there should be renal sodium and water retention. So what happens in conditions which cause conditions like heart failure, cirrhosis? In heart failure and cirrhosis, there is decreased cardiac output resulting in decreased effective arterial blood volume. In nephrotic syndrome, what happens? There is hypoalbuminemia, and this hypoalbuminemia causes reduction in effective arterial blood volume. So this reduced effective arterial blood volume will stimulate the counter-regulatory hormones like renin-angiotensin-aldosterone system, the antidiuretic hormone, the sympathetic nervous system activation. So this will cause ultimately aldosterone production and renal salt and water retention. And this renal salt and water retention tries to return back the decreased effective arterial blood volume to normal levels. So a balance is reached. The edema fluid which is filtered will be retained by the combined with renal sodium and water retention causes edema, because even to cause a small amount of edema, there should be fluid leakage. Fluid in the 2 to 3 liters of fluid should be in the interstitium. So if 2 to 3 liters of fluid is leaking from the capillary alone, this will cause significant hypovolemia and hypotension. So this renal salt and water retention will help to maintain the arterial blood volume and maintain the systemic hemodynamics. So a new balance is reached where there will be some edema fluid and the effective arterial blood volume will be near normal. So alterations in either capillary hemodynamics, which causes increased capillary hydraulic pressures like heart failure or renal sodium retention in renal disease, in pregnancy and premenstrual females, then idiopathic, some cases of idiopathic edema. And in the ICU, when you are trying to resuscitate a patient, you try to give a lot of fluids, 30 ml per kilogram fluid in the first hour. Like that, when you give more fluids, if the patient has mild renal dysfunction, this can produce a fluid overload. Then there can be venous obstruction, which causes increased pressure at the venular end, like in cirrhosis or in DVT or venous stenosis or a chronic venous insufficiency. And the arteriolar sphincter can dilate when you give some drugs like CCB, and in some cases of idiopathic edema also, this mechanism operates. Hyperalbuminemia can be due to either a protein loss in the form of nephrotic syndrome or through the GIT in protein losing enteropathy, or can be due to decreased synthesis in malnutrition as well as in liver disease. Always rule out, always look for conditions which causes capillary permeability. We see this increased capillary permeability in association with toxic bites like snake bite, snake venom envenomation, snake envenomation. We see capillary leak syndromes. In burns, in trauma, in serious sepsis itself, you can see some edema formation will be on the back, ARDS, and some cases of diabetes and patients who are treated with interleukin-2 and malignant ascites also associated with increased capillary permeability. Then lymphatic obstruction, I have already told you it can be due to lymph node dissection or nodal enlargement due to malignancy, hypothyroidism and malignant ascites. There are some drugs which causes edema through unknown mechanism, that is gabapentin. So we have to be careful when a patient comes with edema, we have to check for use of gabapentin and pregabalin also. How will you approach to what will you do when a patient comes to you with edema? First, you have to see whether it is acute or chronic. According to the time course, we have to classify it into acute or chronic. Then we have to see the distribution of edema. Where is it more? Is it in the arms or in the legs or all over the body? Or is it ascites? It is pulmonary edema. These things are important. Second, if it is involved in the peripheries, whether it is unilateral or bilateral, because the differential diagnosis is very much different. And pitting versus non-pitting also gives us a clue, because non-pitting edema is usually due to mixed edema and chronic lymphedema only. So what is the causes of an acute unilateral or asymmetric edema? Almost always is due to DVT. Always exclude DVT in clinically probable situations, like a patient who has been bedridden, has had a fracture, etc. In rest of the cases, 40 days after exclusion of DVT, in rest of the cases due to a trauma or due to a limb which is remaining paralyzed and therefore there is no muscle action, or lymphatic obstruction or a venous insufficiency. Some local infections like Baker's cyst inflammation or cellulitis, some knee abnormalities. So, in an acute unilateral edema, you should always rule out DVT. Second is when you have a chronic unilateral edema or asymmetric edema, the most common cause is a chronic venous disease like varicose veins. You should check for dilated veins in the affected limb, and lymphedema is one another cause, a common cause in our scenario where we are in the coastal region, where we see a lot of lymphedema. Even lymphedema will be pitting in the initial state. Only when the fibrosis sets in, it becomes non-pitting. When the patient has had a surgery or a surgery in a limb or has had a recent trauma, and the patient presents with a swollen edematous limb, you should always suspect complex regional pain syndrome, which was previously called as Sudeck's osteodystrophy. And the best method to sort out between these disorders is a compression ultrasound. So what is compression ultrasound? You do ultrasound, you see the artery, you see the vein. This is the femoral artery and the femoral vein. You give a compression. what happens is that if the vein is compressible means the vein disappears. The vein is compressible means it is not occluded by a thrombus. It is a very easy and bedside investigation. You don't need much expertise. You just get a probe and just press it down and see and make a diagnosis. It can be done in the emergency room itself. Then what about bilateral leg edema? Bilateral leg edema, if it is an acute onset, it is a very, very uncommon problem. It is usually does not occur. And if clinically probable, you should exclude DVT. Clinically probable means post-surgical patients who have been on the bed for some time or who has been immobilized. Then always check for medications which can cause edema. Like the most common medications which we use is calcium channel blockers or OCP, anti-diabetic drugs like pioglitazone, like that. I will be giving a list later. And look for acute heart failure and acute nephrotic syndrome are common causes of acute bilateral edema. Because in what we say about acute nephrotic syndrome is abrupt onset hematuria, edema, proteinuria and hypertension. So that abrupt onset hematuria, proteinuria, oliguria and edema is characteristic of nephrotic syndrome. In such a situation, look for proteinuria and hematuria. And the signs and symptoms of heart failure like orthopnea, dyspnea, S3 gallop, elevated JVP are also important. If none of these findings are there, to exclude DVT, you just check for D-dimer. If the D-dimer is positive, go for a compression ultrasound and Doppler also. And what about chronic? There is slow onset and chronic bilateral leg edema is common in organ failures like liver failure, kidney failure and heart failure. So you should ask for history suggestive of heart failure in the form of exertional dyspnea, paroxysmal nocturnal dyspnea, orthopnea, look for JVP, S3 gallop, bilateral crepitations. And in liver failure, the edema is predominantly in the abdomen and the ascites along with the peripheral edema. And in kidney disease, there will be usually a history of kidney disease. Patients will be usually pale, dry skin. These symptoms and signs of kidney disease should be evaluated. Always you have to confirm that there is no heart disease or liver disease or kidney disease with checking for proteinuria, hematuria, liver functions, renal functions and thyroid functions. And if you suspect heart failure, you should always check for echo also. And sometimes even pulmonary artery hypertension in the absence of heart failure can cause edema. So if heart failure symptoms are not there, still you have to do an echo and see if there is pulmonary artery hypertension. Then another important local cause which should not be forgotten is chronic venous disease. Just examine the legs. There will be signs of venous stasis in the form of hyperpigmentation. Sometimes venous ulcers may be seen, dilated veins. All this can give you clue as to the cause of edema. If none of this is present and you suspect that something is in the pelvis which is causing pelvic venous obstruction, then you have to go for imaging of pelvis. If you are suspecting a gynecological malignancy, go for a transvaginal ultrasound. Or if you are suspecting another pelvic malignancy, you check for a CECT of the pelvis. Now, I have already told you have to review the medications. What are the medications which commonly cause edema? One is the dihydropyridine calcium channel blockers. That is the commonly used amlodipine, nifedipine, nicardipine, etc. Then important causes the thiazolidine diones used for control of diabetes, and then steroids. And the OCP are important causes. A combination pill, the estrogen progesterone combination pills are also important causes. So keep the list in mind. Don't have to by heart everything. Just keep the common things and ask for whether the patient is taking or whether there has been a recent dose hike. That also can precipitate edema. And if such a situation is suspected, you can try and withdraw and see whether the edema disappears, in which case that will be confirmatory. Arm edema is an unusual situation, and when it is unilateral, the diagnosis is usually obvious. Most of the time it is likely to be a local infection or a trauma or arthritis, or sometimes rarely venous thrombosis, especially if the patient is an over-enthusiast athlete they can have some venous thrombosis. If it is bilateral and gradual onset, you check for superior vena cava obstruction. And lymphedema after breast surgery is one of the common causes of upper limb edema. All these things can be sorted with the help of a compression ultrasound with Doppler. Isolated pulmonary edema is one form of edema which should be diagnosed early, because the delay in diagnosis and initiation of treatment can kill the patient. And the patient usually presents with dyspnea, orthopnea, you have all the features of heart failure, but imaging is necessary. A chest X-ray is necessary to see whether it is actually pulmonary edema or are we dealing with pulmonary embolism, because the symptoms in pulmonary embolism is similar, and but the treatment is different. And look for other signs of heart failure and chronic kidney disease. Don't forget that a patient with pneumonia or a leptospirosis can have pulmonary edema in the form of ARDS, in which case diuretics are less likely to work. Don't forget the other forms of non-cardiogenic pulmonary edema, like high altitude pulmonary edema, neurogenic pulmonary edema, and opioid overuse. And the localized edema, ascites, it is actually commonly seen in liver disease and in some forms of heart failure, usually the right heart failure and constrictive pericarditis, which these causes can be differentiated with a paracentesis and ascitic fluid evaluation. Now let's see what is idiopathic edema. After exclusion of all these systemic illnesses and the endocrine problems and the drugs, there is a form of edema which usually occurs in females who are post-pivotal and perimenopausal. Sometimes it can extend to postmenopausal ladies also. This is cyclic episodic fluid retention. They will, by definition, they will all have normal cardiac, hepatic and renal function. One important characteristic is that the fluid accumulation occurs when the patient is upright, and when the patient lies down, the edema fluid is reabsorbed, and this fluid will be excreted in the urine, producing nocturia. There are many mechanisms which has been proposed. The exact mechanism is not known. They suggest that when the patient is upright, the patients develop a capillary leak, a transient capillary leak which causes the edema. And some ladies are very conscious about their figures, so they fast for prolonged time, and after that when they feast, they develop a mild form of refeeding syndrome with the resultant due to increased insulin secretions. And surprisingly, diuretics is one cause for this idiopathic edema, but what most of the time what happens is that the physician who sees the edema for the first time will give a low dose diuretic. Initially it will work, but what happens is that the patient will not be able to withdraw the diuretic. After the withdrawal of diuretics, the renal tubules are actually go into hyper reabsorption mode, resulting in salt and water retention, and this is the diuretic induced edema, because it usually does not occur when the patient is taking the diuretic, but when you withdraw the diuretic, the patient develops edema. And the diagnosis of idiopathic edema is always that of exclusion. You exclude all the serious illnesses which can cause edema, and the treatment is concentrated on, you advise a low sodium diet, and if the patient is on a diuretic, you counsel them that you have to withdraw, but after withdrawal, what usually happens, there will be an increase in edema. If you counsel the patients that this is going to go away, if you stick to a low sodium diet for about 2 to 3 weeks, then this is likely to go away. Then most of the time they will be willing to withdraw the diuretics. And in ladies whom we suspect some form of refeeding, you can ask them to take a low carbohydrate diet. In spite of this, if the edema is persisting, you can advise a low dose diuretic, and along with that you can try a renin-angiotensin system blockade with either AC inhibitors or ARB. But the combination of diuretics and RAS blockade will actually result in some form of hypotension, so you have to be very careful. And there are anecdotal reports of dopamine agonists like cabergoline working in case of idiopathic edema, and a combination of ephedrine and metformin doing wonders for idiopathic edema. So in summary, to make a differential diagnosis of the cause for edema, the distribution of edema, the time course of edema, and the are very, very important. You have to exclude all serious conditions including heart failure, kidney failure, liver failure, thyroid dysfunction with clinical features and appropriate investigations. Always treat the underlying cause. Edema is only a symptom, and life-threatening edema is only pulmonary edema, in which case there should not be any delay in diagnosis and treatment. Always keep idiopathic edema in mind, and where the treatment is centered around avoidance of diuretics and low sodium diet, because diuretics will actually increase the edema when you withdraw it. Thank you for your patient listening.
Thank you, sir, for that wonderful talk. When we use CCBs, we find edema. How do you change from amlodipine, cilnidipine, which drug like nifedipine, which drug you have in your experience, and how do you change it?
Yes. Amlodipine, we commonly use amlodipine and nifedipine. Both of them have equal incidence of edema. The newer L-type and N-type of CCB, they are claimed to have less incidence of edema. I have found that the cilnidipine, ephonidipine, all these things have lesser incidence of edema, but with equal efficacy in blood pressure control. So, if the patient develops an edema, we can counsel them, because this edema is not damaging to the patient. We can counsel them that this is due to the drug. Your BP is well controlled with the drug. If you are uncomfortable because the shoes are tight fitting, and when the people are asking what is the edema caused due to, then if you find it uncomfortable, you can change over to this cilnidipine. Otherwise, if the patient is comfortable and reassured, we can continue with the same drug itself.
Sir, I have a doubt whether this albuminuria can cause edema without hypoalbuminemia. Only albuminuria, but no hypoalbuminemia. Can it cause edema? That's one question, sir. An increase in sodium diet, way more than what's required if a patient takes, can it cause edema? Because I asked this question specifically because one of my patients, he developed edema. He's a doctor, developed idiopathic edema. Most of the workup was negative. Then some nephrologist has suggested him saying that he was taking this nuts, salted nuts. That might be the reason of the edema.
Yes,
So,
in patients who have propensity to form idiopathic edema, increased sodium in the diet can cause edema. Increased sodium in the diet actually causes mainly hypertension. That hypertension will not cause edema. But this increased sodium in the diet in patients who are having a propensity to form idiopathic edema, like the patient already has a increased reabsorption of sodium from the kidneys, or a small amount of capillary leak, that can cause, in them, this increased sodium in the diet can cause edema. Not all patients. In some patients, but we will learn to recognize those kind of patients. So when all the workup is negative, the best treatment for idiopathic edema is a low sodium diet and avoidance of diuretics.
proteinuria
Yes.
without hypoalbuminemia, can it cause edema? Any chance?
That is very, very unlikely, because we see this kind of patients, especially in diabetics. Diabetics usually have proteinuria, some amount of proteinuria, but there will not be much hypoalbuminemia. But the true glomerular diseases, primary glomerular disease which causes nephrotic syndrome, like minimal change disease or FSGS, they have hypoalbuminemia. The hypoalbuminemia in this condition is not due to the urinary loss. It is due to the filtered albumin is reabsorbed and catabolized. So the loss of albumin will be much more than what is seen in the urine. But in diabetes and all, it is not, the proteinuria is not, the hypoalbuminemia usually does not occur, and hypoalbuminemia is essential to produce edema. But sometimes we see diabetics without hypoalbuminemia producing edema. The edema in those conditions are not due to the proteinuria, is due to other reasons for salt and water retention.
Okay, thank you, sir.
Yeah, it was a very good talk, Dr. Joseph, especially for the students' evaluation of edema. Actually, we need to look into the clinical causes before we start any medications. Recently in our hospital we had a case where, as Dr. Amit was telling about hyperalbuminemia and albumin in urine, we had a patient who had come with H1N1 infection, but he developed, he came into sepsis. But then we looked at the parameters, he had features of idiopathic capillary leak syndrome, where you have hemoconcentration, capillary leak, and then we had to, patient had a stomy cause in the ICU. So those patients required IVIG later, CRRT and all. So such cases do come
Yeah,
to
there
the
is
hospital?
a condition in the literature called intermittent capillary leak syndrome. Due to unknown reasons, they develop a capillary leak. Usually due to a small viral infection and all, they develop a severe capillary leak, hypotension, they go for AKI. They have to have, it is very, very difficult to train and associated with high mortality. So that those kind of cases are there, it's been described in the literature also.
Okay. So we had such, we had one patient like that. He is fine now, he is coming for follow-up, but he had a very bad course in the hospital.
Yeah, you remember the dengue patients, they develop this capillary leak syndrome.
Yes.
Sometimes the snake bite persons also develop a capillary leak syndrome, in which case they have a stomach course because the effective arterial blood volume is very low, and whatever fluid we give will leak out also. It will not stay in the system. So it is very, very difficult to treat in such cases.
Hello. What about poroconiosis?
Yes.
Non-filarial chronic lymphedema of the legs. Is it common in India?
I am not sure, sir. I don't know.
Already in Africa, it is very common. Some areas of southwest and northwestern India, it is there. Chronic lymphedema of the legs.
Legs, okay.
Because exposure to dust and silicosis engulfed by macrophages producing chronic lymphatic obstruction. It may be non-filarial. Not very, it is very common in African countries. Okay.
That's a nice presentation. It is very useful. In the past, at least we were dealing with a condition called benign cyclical edema in females.
It is now renamed as idiopathic edema.
So,
renamed as idiopathic edema.
So, and people do say that beta blockers are good for that. Small dose of propranolol.
I don't know. I don't know, sir. I don't know about propranolol. But small dose diuretics, RAS blockade, ephedrine, sympathetic stimulants, metformin, as are supposed to be effective. Yeah. These are only anecdotal reports. There are no studies or RCTs or controlled or any recommendations. Some patients have used and they have got benefits. That's all.
Thank you.
It's not a question actually. I wanted to request the young doctors that when a patient comes with edema and you find that there is low albumin, please don't start AC inhibitors or ARB at that moment itself to stop the albuminuria. It may worsen the renal function because when there is hypoalbuminemia, there is a decreased arterial volume. So intraarterial volume is low. So at that time when you give AC inhibitors or ARB, it may worsen. This is the common practice I see there. So I wanted to emphasize that.
So I had this doubt based on observation. So the first line diuretic that we commonly use is loop diuretic. So even if we stop the function at the level of the loops, there will be further reabsorption at the level of the collecting duct. So why not initially start the patient on something that acts at the collecting ducts instead of the loop?
In nephrotic syndrome, it is advisable to start a combination of aldosterone antagonist along with the loop diuretics. That is why we usually start with the furosemide along with otherwise they will usually develop hypokalemia. But the thing is that this the segment which is handling the maximum amount of electrolytes and where you can do some manipulation is the loop of Henle. At the segment which handles this potassium handling, there the amount of sodium which is handled is only around 5%. In loop of Henle it is around 20 to 30%. So if you use a diuretic which prevents the absorption of 20 to 30% sodium, an increase in 5% to 10% is not going to do much. There will still be diuresis, but the risk of hypokalemia is high. So we usually sequentially block. That is, you use a loop diuretic. Along with that, you block the collecting duct with an aldosterone antagonist also.
Thanks.
If any more questions from the audience, if not, we can close the session. Thank you, Dr. Joseph.
Thank you.
Thank you, Dr. Joseph, sir, for your mind-blowing session. Now, I invite the chairs to hand over the memento and certificate to the speaker, Dr. Joseph, sir. I now invite Dr. Amit sir, Associate Professor, Department of General Medicine, AZEEZIA Medical College, Kollam, to hand over a token of gratitude to Dr. Sanju sir. Also, I invite Dr. Reshma ma'am, Assistant Professor, Department of General Medicine, AZEEZIA Medical College, Kollam, to hand over a token of gratitude to Dr. Deepa ma'am.
Thank you, ma'am. A reminder that we'll be having a cultural fest, Euphoria, a vibrant celebration of the non-academic talents of our very own doctors and students after the next and final academic session. We now move forward to our next engaging session, Angina, the real life experience. Angina is more than just chest pain. It is a clinical signal that bridges the gap between life-threatening pathology and everyday practice. A tight chest today could mean a tighter deadline for tomorrow. To chair this session, we have Dr. Rajashekharan sir, Head, Department of General Medicine, AZEEZIA Medical College. To walk us through this vital topic, we are privileged to have Dr. Nishant Sagar sir, our young and dynamic consultant cardiologist, AZEEZIA Medical College, known for his pulsating energy and exceptional teaching skills. Sir couldn't be here today due to a last-minute personal emergency, yet he has managed to present the session virtually for us.
ഹലോ ഹലോ കേൾക്കുന്നുണ്ടോ? Audible? നീ ഹലോ അവിടുത്തെ നെറ്റ് ഇഷ്യൂ, ഇവിടെ ഫുൾ റേഞ്ച്. വീഡിയോ ആണോ ഓഡിയോ ആണോ കേൾക്കാത്തത്? ഇല്ല. Yeah, so am I audible?
Nishant, good afternoon. Please begin.
Yeah. So, healing the most important point I have to say is in the first slide itself. It's an exercise in humility. So no matter how experienced you are, you might be the biggest of big shots. It is will still miss an episode of angina if you're not very careful. So a bit of statistics to start with. 10% of all visits to the ER are due to acute chest pain. Out of this, 10 to 15% have ACS, and 2% of all ACS are missed and sent home. So this 2% is the data from Western ERs, not from the Indian ones. So that in our overflowing ERs, in our busy lives, we are likely to miss much more cases of ACS. So this is a middle-aged male diabetic hypertensive chronic smoker with severe retrocancer was a surgeon who never practiced a day in his life. We've all read the Netter's Atlas of Human Anatomy. So he earned his living just by making medical drawings. So you can see a slightly obese middle-aged male coming out of a restaurant, clutching his chest. So postprandial is one of the triggers for angina. Cold weather you see is one of the triggers for angina. So he is clutching his chest. So this is the palm sign or the Levine sign. So the Levine sign is a closed fist. The palm sign is an open fist. Both mean the same. It means a cardiac etiology of chest pain. So how do we analyze chest pain is basically on the background of the patient, the nature of pain, physical examination, investigations like ECG, echo, TMT, and angio. Out of which the most important, and in fact, in most cases, what clinches the diagnosis is the nature of the pain. So how we classify chest pain is typical, atypical, and non-cardiac. So typical angina has 3 features and duration, provoked by exercise or emotional stress, relieved by rest or NT. So 3 features: substernal chest discomfort with characteristic quality and duration, provoked by exertion or stress, relieved by rest or NTG. If you have 2, it's atypical. If you have 1 or none, it's non-cardiac. So we often see atypical chest pain or non-cardiac chest pain. This is your textbook description. We often learn that angina is more commonly referred to your left arm. But let's look at the statistics. Radiation to the right arm has a higher positive predictive value, greater than radiation to both arms, greater than radiation to left arm. So radiation to right arm is actually more specific. Associated with exertion, diaphoresis, nausea or vomiting. Worse than previous angina or similar to previous MI. Pressure. What decreases the likelihood of MI is pleuritic patients. So that's again commonly female having chest pain with inframammary pain. Again, less common, not associated with exertion. So this is a classical textbook descriptions. However, diseases don't read textbooks and come and present to you. So what we are going to discuss is real-world presentations of angina, discuss common misconceptions with respect to angina, common errors which doctors make, and finally tips for clinical practice. So we have 4 cases, all 4 were real-life cases. So case number 1, 56-year-old male, no risk factors, presents with burning chest discomfort. He is given IV PPIs. He now does not have pain. He has consumed alcohol and lots of food at a marriage party the day before. ECG at the time of pain is normal. Drop is negative. So, burn with a history of food and alcohol intake. So this patient was actually discharged as a non-cardiac pain. So a better history. So 56-year-old, he had chest pain, no risk factors. Actually, he never checked. Sudden new onset burning pain at 1 a.m., forcing him to get up from sleep. No sweating, conduction, or radiation of pain. Took antacids, no relief of pain. Noticed unusual sweating. Tried to go back to sleep, could not lie down. Had increased discomfort, paced around in the room, came to the T inversions across the anterior leads. So V2 to V6, 1 and AVL, you have T inversions. This ECG was in the pain-free state. So now, is it a cardiac pain versus non-cardiac pain? Do you admit or do you discharge this patient? So it's clearly a cardiac pain and you clearly have to admit these patients. So we often get this history. Patient has consumed alcohol, patient has consumed food. In our part of the world, patient has consumed some jackfruit or tapioca. We get this history very commonly. Remember, patients are humans. They are afraid it's a cardiac pain. So they have a tendency to lead you in the wrong direction. So it provides them some sort of reassurance. So again, this patient was taken up for an angio. You can see a 99% proximal LAD lesion. So this is what we call as Wellen syndrome. So some practical pearls, new or elderly is cardiac unless otherwise proven. Patient comes to you at night with chest pain, it's cardiac unless otherwise proven. You admit these patients, you can even discharge them in the morning. But if a patient comes to you at night with chest pain, please admit these patients. If a patient is forced to get up from sleep, has to sit up due to the pain, and cannot go back to sleep, it is cardiac unless otherwise proven. The same effect as nitrates. So when you give nitrate, your preload reduces. So when you sit, also your preload, your venous return decreases, your preload decreases, your demand of the heart decreases. A normal ECG at the time of chest pain does not rule out the cardiac pain. Remember, you can have 2 to 4% of even STEMIs can have a normal ECG. Normal troponins does not rule out an chest pain. So an ECG ECG is one of the most simplest tests in medicine, one of the cheapest tests. Liberally repeat ECGs. So you can take 2 or 3 or even 4 or 5 ECGs, it doesn't matter. Liberally repeat ECGs. Always try to get ECGs at time of chest pain and when the patient is pain free. So why do we misdiagnose ACS as GERD or reflux? So up to 50% of MI patients have symptoms of APD. 20% of patients describe their anginal pain as burning or indigestion. 15% of ACS patients get improvement with antacids. So proven ACS, they also get improvement. 8% report their symptoms started after a meal. And GERD and ACS frequently coexist. So angina is by history. It is history which gives you a clue, not the investigations. Spend time in taking history of anginal patients. Case number 2. 46-year-old female with history of dyslipidemia came with diffuse numbness all over the chest. Now, numbness is something we don't associate with a cardiac pain. So, heaviness, something sitting on your chest, pressure or burning pain, those are characteristic descriptions, but numbness is generally not. She has a history of inferior wall MI 2 years ago for which she underwent an angioplasty. So this is an ECG. You can see Q waves in the inferior leads. It's an old inferior wall MI. this is the again, relief with nitrates is also one feature of angina. So practical pulse, in general, if a patient has previous angina, subsequent episodes mimic the quality. Prompt relief with sublingual nitrates indicate a cardiac pain, and people perceive and interpret pain differently. Remember, these are patients. Now, patients can perceive and interpret pain differently. There is complaints like vepralam. Vepralam is a Malayalam term which we use. The same vepralam can be interpreted as dyspnea and chest pain or even palpitations. All these three are interpreted by patients to be vepralam. So again, you need to take history So case number 3 in 20 was not taken seriously. Patient was on a ventilator. ECG after 48 hours showed evolved anterior wall MI. So it's all QS complexes. This was actually hyperacute T wave changes of MI. So remember this, MI can coexist with other disorders. Liberally repeat ECGs. So a COPD patient with multiple known exacerbations can again come with another exacerbation. But this time it could be due to an MI. Remember, smoking is a common risk factor for CAD as well as COPD. So liberally repeat ECGs, and remember, MI can coexist with other disorders. And so these are the anginal equivalents: dyspnea, diaphoresis, fatigue, and atypical site pain. So usually seen in elderly, women, and post CABG or heart transplant people. Finally, 5-year-old banker who visited the ED at 11 p.m. one of the famous corporate hospitals. Vague, mild chest discomfort. ECG normal, drop negative, sent home. Advised to attend cardio OP the next day for echo and TMT. 2 days later, again he visits the same ED at 9 p.m. Same complaints. Again, ECG and troponin were negative, sent home, advised to attend cardio OP the next day for echo and TMT. So this was sometime around the late March. So there's a closer of the financial year. So the banker had a lot of targets to meet. So he never came to the cardiology OP. Visited the third time in the ER, patient in hypotension and shock. It's an infra-postro RVMI. So again, patient is in AF. He was in hypotension. He underwent a primary. He was ventilated, had a very stormy course, and finally expired. So again, the practical purpose, if there is a recurrence of symptoms, you admit these patients. Except there are lacunae in your knowledge. Probably your history might not be as good. But if you have recurrence of symptoms, please admit your patient. So learn from the mistakes of others, because you can't live long enough to make them all yourself. So finally, your take-home messages. New onset diffuse anterior discomfort in middle-aged or elderly is cardiac unless otherwise proven. Patient comes to you at night with chest pain. It is cardiac unless proven. You admit these patients. If a patient is forced to sit up from sleep, has to sit up due to the pain and cannot go back to sleep, you consider it to be a cardiac pain. A normal ECG at the time of chest pain does not rule out a cardiac pain. Always take ECGs during and after chest pain. Normal troponins don't rule out ACS. MI can coexist with other disorders. Liberally repeat ECGs. A cardiac pain of more than 20 minutes is usually an ACS. Chronic stable angina usually lasts only for 5 to 10 minutes. If you have cardiac pain of more than 20 minutes, it's likely an ACS. Disappearance of cardiac pain is not always a good sign. It could be a reperfused myocardium or a fully damaged myocardium. And finally, if you have a recurrence of symptoms, please admit these patients. So thank you for your time.
Thank you, Nishant, for your excellent presentation. Any questions from the audience? Please listen. Anybody having a question? Dr. Nishant, are you online?
Yes, sir. Yes, sir.
Could you just add a word on angina equivalents?
So, angina equivalents are generally dyspnea, diaphoresis, fatigue, atypical side pain, even profuse sweating. So, the problem with an anginal equivalent is that you should be you should be very sure whether it's actually an anginal equivalent. So, for example, a patient having new onset dyspnea, so a patient who's perfectly normal suddenly develops maybe for 2 weeks, he has exertional new onset, that can be considered to be an anginal equivalent because we have this gray area, so people can easily interpret it to be an anginal equivalent. So if it is a new onset dyspnea, especially in a middle-aged or elderly, you can consider that to be an anginal equivalent, especially progressive and higher grades. Similarly, sweating, especially if it's unexplained, if you have, those can be considered to be anginal equivalents. So fatigue and atypical side pain. So atypical side pain means you can have only jaw pain, or only neck pain. There are even patients who presented only with toothache. So all of these are atypical side pain. However, remember, diagnosing anginal equivalent is not that easy. There are a lot of errors can be made in this diagnosis of an anginal equivalent.
Thank you.
Especially consider new onset dyspnea. So new onset dyspnea, functional class, and etc.
So I think I got one more question. Can you get an angina with a normal coronaries?
Yes. Yes, sir, you can get angina with normal coronaries. So actually, if you do an angiogram, you're only seeing the major epicardial coronary vessels. So there is an entity called microvascular angina. So the epicardial coronaries are normal, your microvasculature is dysfunctional. So that is usually seen in middle-aged females with a lot of risk factors. So that mimics typical angina. So it's called ANOCA, angina with non-obstructive coronaries. So it typically mimics an angina, and you have to do an angiogram and you'll find normal coronaries. Then that's when you suspect whether it's an ANOCA, angina with non-obstructive coronary arteries.
Okay, any more questions? Just anybody? Thank you, Nishant, for your excellent presentation. It was fine. The practical tips for every practicing practitioner to go forward in the clinical career. Thank you very much. Have a nice day.
Sure, sir. Thanks.
Thank you, Dr. Nishant, sir.
Now I think the scientific session is over. For vote of thanks, I call Jas.
So once again, good afternoon to all. So it's a time to wind up the academic section. And at this moment, actually I would like to thank a lot of people. Starting from the mentor, Dr. Ashain sir and Srikanth sir, who have put an idea to carry out this program. Special thank to our HOD sir and Srikanth sir, and all the faculties of Department of Medicine, and my dear PGs, who have run a lot for this program to carry out somehow a successful one. And of course, the other non-clinical staff, our secretaries and other staffs has played an important role to put up this CME. And from the top to bottom of AZEEZIA, I would like to thank for the security department, the facility department, the IT, electricity, water department, especially our lift operator Chetan. And I would like to thank, special thanks to the chairpersons and all the delegates who have reached here, sparing their Sunday. And so many has spent the whole time here with us. And I would like to give a special thanks to Namada Deepu Chetan. Deepu Chetan is representing a pharma company, and he has been with us from the day of decision. We started to plan for the CME. Registration ആണെങ്കിലും എല്ലാ കാര്യങ്ങളും ഈവൻ നമ്മൾ ചില സാഹചര്യങ്ങളിലൊന്ന് തണുത്ത് പോയാലും മുട്ടിൽ ചൂട് പിടിപ്പിക്കാൻ ദീപു ചേട്ടൻ ഉണ്ടായിരുന്നു. ഇന്നിപ്പോൾ രാവിലെ ചില സമയത്ത് ഞാൻ ഔട്ടായിരുന്നു, പക്ഷേ ദീപു ചേട്ടനാണ് ബാക്കി കാര്യങ്ങളെല്ലാം അറേഞ്ച് ചെയ്തത്. സ്പെഷ്യൽ താങ്ക് ടു ദീപു ചേട്ടൻ ഫ്രം ദ അക്കസിസ് ആൻഡ് അവർ കോമ്പയറിംഗ് ടീം, ദ വോളണ്ടിയർ ടീം, ഓഫ് കോഴ്സ് ദ ഓഡിയോ വിഷ്വൽ മീഡിയ, ദ സ്റ്റേജ് ടീം. കാരണം നമ്മൾ ഇടയ്ക്കിടയ്ക്ക് ഇവിടെ ചെറിയ CME ടോക്കുന്ന രീതിയിൽ എല്ലാവരും കൂടാറുണ്ട്. പക്ഷേ മങ്ങിയ വെളിച്ചത്തിൽ ചുമരിൻ്റെ ബാക്ക്ഗ്രൗണ്ടിൽ ചെറിയൊരു 50 ഇഞ്ചിൽ ചെറിയൊരു
ഡിസ്പ്ലേ അത്രേ ഉണ്ടാവാറുള്ളൂ. ഇങ്ങനെ ഒരു സാഹചര്യം ഒരുക്കി തന്ന സ്പെഷ്യൽ താങ്ക്സ് ടു ഓഡിയോ വിഷ്വൽ ആൻഡ് ദ സ്റ്റേജ് ടീം ആൻഡ് സ്പെഷ്യൽ താങ്ക്സ് ടു അവർ ഡയറക്ടേഴ്സ്, പ്രിൻസിപ്പൽ മാഡം ആൻഡ് all who have gathered here and give permissions. They have give permissions to make this successful one and the students. അങ്ങനെ പറഞ്ഞു കഴിഞ്ഞാൽ നീണ്ടു പോവും. നമുക്ക് സമയം കുറച്ച് കുറവാണ്, അറിയാം, സമയം വളരെ വലുതാണ്. സോ വലിച്ച് നീട്ടുന്നില്ല. Again, I would like to thank all of you who have reached here, who have given the support mentally and physically to make this program a successful one. We would like to wind up the academic session with a national anthem, and we will be moving forward to the small cultural event named Euphoria in the background of ADAMCOM 3.0. Thank you.
Thank you all for your active participation. We hope this conference has been a meaningful and insightful experience for all of you. Wishing you safe travel and continued success. See you at next event.
So everyone, please stand up for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे.
സഞ്ജു എപ്പോൾ പോകണം? ഓക്കെ, ശരി ശരി, ഓക്കെ. ജസ്റ്റ് ഒരു 1 hour ഞാനും പോകും കേട്ടോ. അല്ല ഈ പിന്നെ നമ്മുടെ ശ്രീകാന്ത് സാറിൻ്റെ വൈഫിനെ അവിടെ പാച്ചോട് പോയി.
ഡിസിപ്ലിൻ പ്ലസ് മറ്റു സാധനങ്ങളൊന്നും ഇതാക്കരുന്നല്ലോ.
ഏതാ
ഒരു എൻജോയ്മെന്റിന്റെ ഇടയിൽ സാധനങ്ങളൊന്നും ഇട്ട് മറിക്കരുത്. സാർ ഒന്ന് അനൗൺസ് ചെയ്യും. ഡിസിപ്ലിൻ മെയിൻറ്റെയിൻ ചെയ്യുന്നത് സാർ ഒന്ന് അനൗൺസ് ചെയ്യും.
അത് ഞാൻ പറയാം. Can you hear? I think the PGs can come forward. Asad, Adil, Adarsh, Archa. Where's Archa? Come. And the comparing team. Come. And this time, ഇന്ന് ഈ ഒരു അവസരത്തിൽ നമുക്കൊരു ലിബർട്ടി ഡയറക്ടേഴ്സ് തന്നു ടു കണ്ടക്ട് എ കൾച്ചർ പ്രോഗ്രാം അണ്ടർ സ്പെഷ്യൽ റിക്വസ്റ്റ് മിജാസ് ആൻഡ് മീ. അപ്പോൾ അത് ഒരു ചിട്ടയോടും ഡിസിപ്ലിനോടും കൂടി എന്താണില്ല നടത്തേണ്ടത് ആവശ്യമാണ്. അങ്ങനെ തന്നെ ചെയ്യുമെന്ന് പ്രതീക്ഷിക്കുന്നു. യു ക്യാൻ സൂപ്പർവൈസ് ദോസ് തിങ്സ്. ദ മൊമെൻറ്റ് ഇറ്റ് ഗെറ്റ്സ് ഔട്ട് ഓഫ് കൺട്രോൾ, ആ സമയം അപ്പം നിർത്തി വയ്ക്കും. We are free, but the freedom should be in the concerns of discipline. I think others, Adil, Asad, Archa, you will monitor those things. Anybody deviating from the anticipated protocol will be thrown out of the room. Okay? Thank you.